Welcome. My name is Eileen Wetzel. I'm the CEO of the Sierra Sacramento Valley Medical Society, and it's my pleasure to welcome you all back to our first in-person Joy of Medicine Summit. In the past 2 years, we've been virtual, so I'm really pleased that we're back in person. Yes. And it's wonderful as I've watching you all come through the door, faces that I know, people that I adore and that I love, to actually see you in person again. And some of you even let me hug you, so I appreciate that. That means the world to me. Very good to see all of you, and very good to see remotely many of your colleagues that are joining us on Zoom today. So we are in a hybrid format, so hello and welcome, and we hope you enjoy the program. So I am thrilled to introduce to you our MC for the day, Dr. Rajiv Mesquita. Rajiv was one of the founders of our Joy of Medicine program, and he's actually the original chair of our Joy of Medicine committee. He's the chief of Lifestyle Medicine Department at Kaiser Permanente South Sacramento, vice chair of the TPMG Board of Directors, and past president of the Medical Society, and probably one of my favorite presidents. And I'm just saying that because there's not many in the room. Dr. Mesquita has dedicated himself to transforming his life and the lives of colleagues and patients. He is a certified, in addition to being a doctor, he's a certified yoga instructor, a personal trainer, a plant-based chef, and an author. If you haven't read his book about plant-based eating, it's absolutely fantastic. It's worth picking up. So please join me in welcoming Dr. Rajiv Mesquita.
Thank you so much. Eileen, you probably say that to all the past presidents. No, just kidding, but thank you. It's great to be here. It feels like it's been a long time because of COVID and the pandemic. A lot of us have been sort of holed up in our offices using Zoom and all of that. And it's really, to me, it feels great to finally see people and interact in person. I actually returned from DC 2 days ago, where I was at a meeting where people were actually getting together, and it felt so good, just to meet people and reconnect. And I think, COVID robbed us of that one thing that, as physicians and professionals, we can, meet and connect and share our stories and ideas. And I'm hoping we can slowly get back into it. So I'd also like to thank you for being here so early in the morning on a Saturday. I know that's a sacrifice, and thank you so much. And, I think you're going to enjoy the talks today. It's going to be well worth it. So welcome. You probably heard some of my stories, so you'll be in for a little bit of yoga stretches, just to warn you in between. It will be fine. You'll do okay, but hopefully it'll invigorate you. So I'm going to start off with first. Let me get the first slide here. Am I able to advance this, Sam? Okay, perfect. Thank you. I'd like to thank the members of the Joy of Medicine Advisory Committee. You'll see the whole list there. I'm not going to read the whole list off, but it's a huge list of physicians, and there's psychologists, medical students, just a combination of different folks from different medical centers and even healthcare organizations in Sacramento. And they bring all their talents together to help develop a lot of these programs. I recall when we first started this 6 years ago, as Eileen mentioned, there was a need in Sacramento to bring some of this information and try to bring physicians and professionals together, considering all the stress we face. And so this is actually the 6th annual conference. I can't believe it's the 6th. I remember doing the first one. It seems like time has just flown by so fast, but the topics look really fantastic. So I'd like to, recognize all these folks who are part of the Joy of Medicine Advisory Committee for putting in all their time, and it's mostly times in the evenings that they dedicate to this. Let me go back. I also want to thank our sponsors who are listed here. They actually help fund some of these programs. There's the Cooperative of American Physicians, Sutter Medical Group, Physicians Foundation, there's WCMG, NorCal Group, Sutter Independent Physicians, Hill Physicians, the Plaza Nevada County Medical Society, the Permanente Medical Group, Mercy Medical Group, and UC Davis Health. So we're thankful to our sponsors. Also, an important note, you're going to get CME for this, so make sure you fill out a survey at the end. In order to get your CME, you're going to have to fill out a survey at the end of the program. There are a whole number of people who are actually listening to this virtually through Zoom. So for those of you on Zoom, you're going to need to get a link to the survey. So you'll have to email Sam Mello. And Sam, I think Sam has probably already sent you the invitation, so you should see her email there. So it's Sam Mello at SSVMS, and she will send you the link to get your 3 hours of CME credit. So don't forget that. Also, you probably noticed some massage therapists on the side. If you haven't, I'd recommend you take advantage of that. They're going to be here till 10:30, I believe, and so so that will contribute to your wellness as well. And so feel free to go there and get your massage. You should still be able to hear the talk while we're doing that. And if during the talk you feel like sitting is too much for you, stand up. You know what they say: sitting is the new smoking. So so don't sit for 3 hours. Feel free to stand up. Stand to the side. Grab something to drink, pace around a little bit, just move around, but don't hurt yourself. Let's see here. Oh, that's it. That's the end of it. Okay. So, once again, I'm really delighted to be here and delighted to see all of you and those who are on Zoom as well. We're so glad you're with us. And I'm excited to actually introduce the first speaker. I had an opportunity to speak with her actually initially before we started. And it was really pretty exciting. So the speaker's name is Elizabeth Morrison, Dr. Elizabeth Morrison, who has an interesting background. So I'm just going off what I talked to her today. She actually was born in Edinburgh in Scotland, and then moved to Alaska, but returned back to Edinburgh to get her PhD in psychology. And then went back to Alaska to practice, and then was recruited to Modesto by the CMO of our organization to help them with their behavioral medicine program. And she has her own company now and is a consultant. And one of her interests is in developing that empathic connection between patients and providers and physicians. And how do you develop that, and how does it affect care? And so she has some intriguing information I'm sure she's going to share with us on the benefits and what occurs with these connections that we develop with patients and how it can actually influence and help us. And I'm looking forward to this talk. Dr. Morrison, if you could come up here, please. Please welcome her.
To give a huge shout out to Eileen and Sam and Brandon and Michelle and like the SSVMS team, because they're amazing. They're amazing. It's the first hybrid and super not without stress trying to figure that out. And so I'm just so impressed. And yeah, you're doing a fantastic job. Okay, thank you. Yeah, well, the first thing that I wanted to share is I sent this email to a colleague of mine where I live in Modesto. Not a colleague that I know super well. And I got back like this email, and the preview of the email said, "Thank you so much for your email. It's awesome. You're awesome." And I was like, oh my God, I feel great. Like that feels great. And then I clicked on the email and it was an automatic response. I know. But the crazy thing was I still felt great. And that was so interesting to me, psychologically speaking. I was like, how does that still feel great when I know it's an automated message? And it's really consistent with this research around smiley faces on receipts, that if people get a smiley face like on a receipt, that they feel closer to the business, that they feel more loyal, that they feel like they got better customer service. So anyway, this is very recent email that I got. So what I want to tell everybody is, yes, I don't know all of you, and I know that you're awesome, and I have been able to talk to some of you, which is amazing. And as I do other work with SSVMS, I'm helping them with their increased MAT for pregnant women in Sacramento County. And everybody that I have contact with is just super awesome. So that's the takeaway today. If you don't take away anything else, this will be the takeaway. So I wanted to, I'm going to talk just about patient interactions, and I see patients at my FQ still, even though, I left as a leader of the FQ. I still see patients there and think about this all the time. My doctoral research was on receptionists' interactions with patients and the impact on healthcare outcomes. So I'm interested in therapists like myself and patients and physicians and patients and other medical providers and patients and receptionists and medical assistants and all of the different ways that people interact, like who the patient touches and what those interactions look like. So I just wanted to ask you all if you can just think about that for a minute, not necessarily what patient outcomes feel rewarding, like when people get better, for example, but the actual interaction in the exam room or in the Zoom room. What makes them feel rewarding to you all? And then I'm going to ask you the same question about what interactions drain joy. Again, not necessarily the outcomes, but like what about in the interaction just feels unrewarding and draining? And then what I'd like to do is, for those of you who are on Zoom, hi to everybody on Zoom. If you capture this QR code with your phone, or for those of you who are here, if the QR code is too far away, if you pull out your phones, you can go to menti.com, which is menti.com on your phone, and you can put in this code. So whatever's easiest for you. It's just so you know, these questions are totally anonymous to me too. And it's just a way to hear from the people who are on Zoom, to hear from all of you in the room, where we can sort of see each other's responses. And so I'll just leave this up for another minute, and then we'll go to a screen where you can see what everybody has typed in. But I really, really like to hear from people, and sometimes in like big groups, and when we have like some people, many people on Zoom, it's hard to hear from everybody. So it's just a way for us to do that. So I can see that many of you have already been able to get on. If you haven't been able to get on yet, at the very top of this slide is the menti.com website and the code that you can put in to get to where you can type in. Patient gratitude. Yes, gratitude is super rewarding. It's the opposite of entitlement. And entitlement typically is very unrewarding. Gratitude, other people I see gratitude. Yeah, I love this one, connecting to them as a person to person, more than patient and doctor. That's what I'm going to talk about today, is that human to human connection, personal connection. Yeah, patient disrespect, I know probably belongs on the second question. Really connecting with people saying thank you. So gratitude, connection, person to person, heartfelt compliments, smiles. Smiles are universally rewarding. They're the only way that humans know that we have goodwill towards them. So mask really messed up our mirror neurons for that. Yeah, gratitude, connection, appreciation, improved spirits. Gosh, yeah. So there's lots of similarities for sure. Gratitude and real connection, real human to human connections. Hugs from the kids. I love that. Yeah. Yeah, people asking insightful questions. So I'm so happy to see these, because it's what I'm going to talk about today. And if you'd written something different, I would have tried to pivot. But that kind of having those relationships with patients where they genuinely feel grateful for how hard we're working and what we're doing for them. And then also just the connection as people. It's not so rewarding for most of us to connect with the disease or the condition. It just doesn't have the same reward. So of course, I want to ask you this one too. What type of interactions drain us? And that should come up on your screen in the very same way. Curious about this one too, if there might be a lot of similarities or if people have different ones. I gave an example of one of them. For me, the opposite of gratitude is like entitlement, and entitlement is probably the thing I dislike, like it's the least rewarding for me with patients. Yeah, resistance, demanding, entitled, demanding, that's right there with me. Entitlement, argumentative, disrespectful. Yes, God, demanding is huge here. Ungrateful, right? The opposite. Zero emotion, super flat can be really tough. Sighs and dissatisfaction. Yeah. Entitled, demanding. Yeah. When patients yell. God, yes. Yeah. Psychological issues as somatic symptoms. I know. Stomach aches, like headaches with no known etiology. Yeah. Nastiness before even getting started. Impatient. The yelling. I love that that person put it in all caps. Yeah, verbal disrespect. So I do see a lot of similarities, certainly anger, certainly entitlement and demanding is really combative. I want to tell you that I want to give a shout out to Lindsay Coate, who is there helping with the Zoom setup and is an SSVMS core staff. And she was the one that I talked about this workshop with. And she was torn between, I do a lot of de-escalation training. And she said, we were torn between de-escalation training and like rewarding interactions. And I can see here, there's a lot of anger and yelling. I do a lot of de-escalation training. And I always ask, have escalations increased, decreased, or stayed about the same in the last 12 months? And everybody's increased, everybody. So the good news about this is the strategies I'm going to talk about today also work as preventative escalation strategies. And sometimes they work for early intervention on escalations, before somebody really fires up. So thank you all. Thank you so much for doing that. It's just a great way to hear from you. So I appreciate that. Let's see. My slides aren't advancing. Oh, I'll use the remote. I got it. Yeah. Okay. I wonder if I step away from the mic, if you can all hear me. Yeah. Oh, okay. So this is a true story. My mom's deaf and she didn't get hearing aids until I was 16. She wasn't part of the deaf community, never got tested. She's 87 or something. So she never got tested when she was a kid, sat in the front of the class, figured out how to get things written and read lips. And so when I was a kid, she couldn't hear the phone, she couldn't talk on the phone. She couldn't hear the doorbell. And so my sister, my brother and I are super loud because the thing was, she was like, look at me, right? It was always like, look at me and like really yell. And so I'm super loud. And sometimes my husband's like, your mom is not in the room. Like, so I always feel like I'm just really loud. So one of the things, what I'm going to talk about today is the foundation for rewarding interactions. There's a lot of foundations, of course, but the ones I want to talk about today are autonomy, and that's in contrast to control, and empathy, and that's in contrast to judgment. So all of you who have kids or who have kids in your life, or significant others, you probably know that when you're trying to make somebody do something, it basically crushes the connection. And that's totally unfortunate because we want people in our personal lives and patients to do a lot of stuff. And if the more we try to control, the worse the connection gets. And then the other piece is we all have judgments. We're human. We don't have to judge ourselves for having judgments. And when we have judgments about somebody, it's almost impossible to have a rewarding interaction with them because it's the opposite of empathy. So I'm going to toggle back and forth between my own examples from patients, examples from people I work with, and personal lives, because the strategies I'm going to talk about today, you're going to recognize them. You're going to say, oh, I do that. So one super good outcome at 10 when I'm done is if you all pat yourselves on the back about your evidence-based empathic communication. And you'll recognize them from your personal life probably too, because there's no difference between the things I'm going to share about how they work in our personal life and how they work in our professional life. And I want to give you an example of that, which is, this is my mom. This is her, well, I say this is her boyfriend, but she's like, I'm 87, he's my gentleman friend. So if, just as a side note, if you want to be horrified, buy your mom an iPhone and sit in the kitchen with her while she scrolls through a senior dating app showing you people. It's horrifying. It's horrifying. That's what happened to my mom. Like, oh, what do you think of him? I'm like, no. Like, so thank goodness she met John pretty early on in the senior dating scene, and they've been together ever since. But and on the right is my son, who is, there's probably better ways to say this, but he's not an easy kid. I'll just say he's not an easy kid. He's not the kind of kid that adults are like, wow, I love him. No. So it's good for parenting ego, because I had a daughter that every teacher loved and every adult loved. And I got to feel like really great about my parenting. And I was like, I know, she's great. And then I got this guy where everyone's like, oh my God, what kind of parent are you? Like he's tough. So the reason I toggle back and forth between personal life and like seeing patients is because even though I make light of this sometimes, the consequences of a lack of empathic communication are actually super deep. And my mom's a good example. Of course she loves me. Of course she loves my son. Like she has a ton of love in her heart. And when she opens her mouth, it does not come out. There is a disconnect between what is in her heart and what comes out of her mouth. And as a result of that, we're not very close, right? She's the person that when I, had a little baby who had colic for 18 months, and she'd say, what's wrong? You look tired. And I would say, I never sleep. And she'd say, you wanted to have a baby. That's just my mom. That's just how she is. And my son, like I had an interaction just like when my son was maybe 10 and he came into her house crying, the time where you would most have empathy with someone, where they're just most vulnerable and all your empathy is welling up. He was crying. He had like road rash on his hands. He'd fallen down in her driveway. And I got up to like go to him and she said, why were you running in my driveway? So I'm sure many of you have a Gene Morrison in your life like this, someplace in your family. But part of what I find so heartbreaking about it in seriousness is that my son doesn't think she likes him, which means he doesn't think she loves him. And he doesn't want to ever go over there or spend time with her because she just judges. She just criticizes, she judges. And so they have no relationship. And so part of the reason I share that is the consequences are really serious for having empathy here, but not saying it, like not figuring out how to stop judging, stop criticizing, stop trying to control and push, and just sort of be and look at someone as like an amazing human and share back with them what you like about them and ask them questions about their life. She doesn't do any of that with him. So there's nothing to like weigh out this piece of their relationship. So if we think about with patients, and how cramped our time is with patients and how hurried we are and how much we want to get them to do stuff, sometimes it can squeeze out the very skills that would allow us to connect with them as humans and to have like a rewarding, empathic, kind relationship. So I like to think of empathy. Stigma is one word that we could use. I also use the word judgment. I also use the word bias. If you think about the other side of this teeter-totter, it's really negative judgments of any kind are like in direct proportion to empathy. So the more empathy we feel for someone, the less judgment we're feeling. And the more judgment we're feeling for someone, the less empathy we have. So that's kind of a conceptual framework for what I'm going to talk about. So I think that probably many of you know this. I'm a huge nerd about the research on empathy and its impact on treatment outcomes. I have an extensive bibliography that's annotated that I'm constantly adding to, that's on my website, which I'll give you at the end if you have interest in or have some interest in some of the research that I'm going to talk about today. But part of the reason I want to talk about it is when we talk about empathic communication strategies, I want to talk about the reward to us. And first, I want to talk about the reward to the patient, the outcomes that are the result of our empathic communication. And sometimes there's a bunch of research in how empathy treats medical conditions all by itself as a single treatment and as an auxiliary treatment. There's a ton of research in the mental health field. And I met a psychologist here today. Psychologists or LCSWs? I'm both. Just you and me. Okay. Probably on Zoom though, probably on Zoom. So substance use disorders, a ton of research in empathy and substance use disorders, and in intimate partner violence and parenting and vaccine hesitancy and like fill in the blank. There's research on empathy and all of these things. I'm going to talk a little more specifically about them. But before I go on, I also want to say that there's research on what judgment does for all of these things too. So the opposite is true. Empathic communication, of course. I was just talking to Rajiv about his lifestyle medicine department and program, and how big a part motivational interviewing is of that. So I just wanted to put out that when I'm talking about empathic communication, I am talking about evidence-based empathic communication, and it is the foundation of all behavior change strategies, because if people don't feel like we care about them, they never do what we suggest. And it is the foundation of trauma-informed care too. So just a couple super fascinating research studies, and would love if people have heard of these or want to add more, like please feel free. But there's super interesting research on the common cold. That when people come into our systems with a common cold, if they feel empathy, not just from the physician, but the healthcare team. So empathy is sort of an equal opportunity strategy. Like I said, my research was on receptionists and empathy or lack of at the front office. Medical assistants, nurses, case managers, et cetera. In fact, I have this workshop that I call, if you want to improve your patient's A1Cs, you better get a nice receptionist, because it has a huge impact. But when someone comes in with the common cold, there's really interesting research that shows if they're met with, if they feel the empathy, because remember, it's not about what's in our hearts, it's about how accurately we're able to communicate it, that their symptoms last for less duration and less time. It's replicated research. We know that with pain control, and this isn't even self-reported pain control, this is when they do brain imaging to show that when people feel empathy, their pain goes down. When people feel judged, their pain goes up. So all of the chronic pain patients that have been judged in like every system they go to, and then they show up with you and they felt judged by the receptionist, and they start, you feel like they're exaggerating their pain. They actually are feeling more pain. Substance use disorders, one of my favorite pieces of research in our field is called toxic therapists. And it's about therapists leaking judgment about substance use disorders to their clients, and the clients leaving and using more. There's also lots of research on this in the medical field as well. Empathy is also an evidence-based treatment for anxiety. The diabetes research is super interesting. The N's really big, and it's been replicated a few different times that we see greater A1Cs when patients feel less empathy. We see lower A1Cs when patients feel more empathy. And so, like I said, they study this alone and then study this, of course, with other treatments. And depression, we see movement in a PHQ-9, and for anxiety with a G87. So it's endlessly fascinating, the research on this. And like I said, unfortunately, the opposite is true. So judgment, stigma, bias, the more that flares up, the worse these conditions get. Back to kind of like what, as I was talking to Lindsay and the SSVMS team about like really what I really wanted to talk about today is, yes, it's good for the patient when we have an empathic connection with them. Yes, it's super good for them when we have a human-to-human interaction, when they feel like a human, and not a condition or not a number. And for our purposes here today, the most important thing just right now is that it's also the most rewarding for us. That it's really that human-to-human, kind, connected, relational interaction that typically, the more of those we have during the day, like if we see 22 patients, if we have a preponderance of those kinds of empathic connections, even for a minute, even for 2 minutes, then we typically leave feeling much less drained and more rewarded. If we have more of those, like, everything you put on the Mentimeter about the lack of rewarding interactions, then we leave feeling particularly drained. So I'm going to talk about just these 3 core strategies. There's endless ways to communicate empathy, just endless. And there's mountains of research on like every single one. But I'm just going to talk about 3 of them because for a couple reasons. Super interesting research on these 3. They're ones that I use super imperfectly. In fact, because I do so much research, practice-based research now, and talk so much about empathy, it's totally unfortunate that my kids are like, what the heck? Hello, aren't you like a teacher of empathy? Like when I'm snapping at them, like it's really super lame. I remember I made this workbook. I'll show it to you at the end. It's on my website for free if you want to look at it. But I made this empathy workbook and I asked my daughter to proofread it for me. And so she did. And then like the next week, like I said something to her that was like super judgy. And she was like, oh my God, like that was in the workbook not to do that. I'm like, So I don't do them perfectly at all. I don't talk about this because I'm the most perfect empathic communicator. I talk about it because I love it. because I'm interested in it and I practice. Like I'm just always practicing. One of them is open-ended questions. And you probably know the Institute of Medicine actually calls this the gold standard of all communication. And totally unfortunate that our EHRs and almost all of our standardized assessments are closed questions. So we really have to work around the systems that we're in to actually land into open-ended questions. But there's actually there's a ratio of this. It's 1 to 3, that we need 3 open-ended questions to every 1 closed question for someone to actually feel listened to. Because when they say he listened to me or she listened to me, they're saying, I feel like they care about me, right? People hold listening and care together. Also, open-ended questions, side note, is related to diagnostic accuracy. It's true in my field, it's true in your field. And of course, the reason why is, when I do a depression assessment and I'm essentially saying changes in appetite, changes in mood, hopeless thinking, yes, no, yes, no, yes, no. And I never say, what are your thoughts about this? Like, what do you think might be going on? I never hear that they're drinking or that their mom died last week or that they went off medicine that they've been on for like 2 years. Like, we never hear the really rich assessment information when we're stuck on closed questions. So, and super importantly for what I'm talking about today, open-ended questions convey interest. They convey autonomy. Like, we're not trying to push someone into something like, don't you think you should? Have you ever thought of? Like railroading somebody. So that autonomy piece sort of fires up for people. And openness. Empathic reflection is essentially repeating back to people. I used to call it reflective listening, but I think most of us have been on the other side of super unskillful reflective listening, and it kind of feels bad. And so now it's like sort of in the field, and I've changed my language to empathic reflection, which means like really skilled repeating. Because when I call Sears because the dishwasher's broken and they won't replace it, even though I call them all the time because it doesn't meet like the warranty for a replacement, and every single time they say, I hear your dishwasher's broken. I know they have a script and that they have to like repeat it. And if anybody's, it's kind of like a joke in marriage counseling, like, Joan, tell Steve what you hear Steve saying. So what I'm talking about here is genuinely skilled reflection, like letting people know, I hear you. And then affirming strengths, which is the most fun thing ever, and typically is one of the main things that allows us to connect to our patients as people. And I would say that's true for our kids too, our kids and other people in our lives. So open-ended questions, of course, it's any question you can't say yes or no to. I want to add something though to this definition, that it's not a narrow question. So open-ended questions start with what or how, or tell me more. I basically only use tell me more. I'm forever in sessions. I see the other psychologist, hello, is nodding, right? You can track and guide an entire session by saying, tell me more about that. Tell me more about that. And you can even bring people back onto fertile ground, right? When someone starts storytelling and they're like, and then he said, and then she said, and you're like, oh no, like, oh, I'm already running behind. Where are they going with this? Like, it's also a way to get people back into fertile ground. Hey, can I go back to something you said a minute ago? It's super important. Can you tell me more about this? How and what are great. How did you make that decision? What are your thoughts about this? How are you thinking about this? Why is an open-ended question super important to avoid? I've been trying, like for 20 years, I've been practicing like weeding out the word why from my vocabulary. Because it sounds judgmental, even if it's not meant to be. So if anybody's ever asked their kids, why did you do that? You get bad information because they don't know why, or they're defensive. They're like figuring out like, wait, what's happening here? Why are you asking me that? And it's the same for patients. When we say, why did you stop taking your medicine? We genuinely probably want to know, why did they stop taking their medicine? And we typically will not get rich information, and it tends to sound judgmental. So I want to add, these are closed questions and narrow questions. So did you have a good day? Have you thought of, and do you want to quit are all yes, no questions. Those are the ones that we want to avoid if we want like that human to human connection. Which medications are you taking is what we call a narrow question. A narrow question is me asking you how many siblings you have, me asking you where you live, even me asking what are your hobbies is really narrow. So anything that like narrows really far down what someone can answer, like where does it hurt and which type of medicine are you taking? So this takes some practice, I think. Like I said, I feel like I just am always practicing, figuring out how to ask information in an open-ended way that's going to get me better information and is going to build that relationship with the patient. And then, you know, a lot of times there's stems, like it sounds like I could hear, if I'm hearing you right, if I'm understanding you. These are sort of empathic reflection stems. So what I'd like to do today, and I know the introverts are like, no, it's not a game. It's not an icebreaker. It's not embarrassing. I know maybe the extroverts are like, thank God she's not going to keep just talking at us. So I know there's like a mix of how people come to this, and that our Zoom folks aren't going to be able to do this. So, but what I would like for people here is if you can pair up, and there's 3 of you at the table, at a lot of tables, so you can do 3s if you want. If you could turn around, you could get a partner there. And just, this is like a 4-minute exercise. So when you pair up, decide who's going to do the open-ended questions in the empathic reflection first. And then just turn to the person and say, tell me a little bit about what brings you joy, or what brings you joy, or how do you think about like what brings you joy? Like some open-ended question to elicit something that brings joy. And then after your partner tells you, just reflect back. Just say, gosh, I really hear how much working in the garden brings you joy. That's it. Open-ended questions. You get a chance to talk to your colleagues. We're not role-playing. This is like really just talking to your colleagues. You get to hear about joy. I don't have my phone up here, so I wonder if, Brandon, can you set a timer on your phone? Okay. And for those of you that have 3, if you can just switch so that everybody has a chance to talk and everyone has a chance to practice. Super short exercise. So if you can set it for 4 minutes, Brandon, it's fast. So go ahead. And for those of you on Zoom, thanks for sticking with us. Right, that's right. Okay, everybody, finish up. That's okay, I'm good. Finish up your last person and come on back. All right, everybody, come on back. Come on back. I see a lot of people smiling. I hope that's because connection just feels really good, and that's what we're talking about today. All right, come on back. So I was looking over at Bianca just now, and I forgot one of the things I wanted to say, which is, I was so excited to come here when Lindsay asked me to do this workshop, and not knowing that I would my son is in a soccer tournament today that I'm getting back to. So I won't be able to stay for the other speakers. And I really wanted to hear Bianca and Taylor speak. But then Rajiv told me that everything's recorded, so I will actually hear you. So I wanted to just apologize in advance, because it's one of the benefits of being a speaker at an event like this is to hear the other speakers. So I'll have a slight delay on that. But thank you for all for doing that. I'd love to hear from 1 or 2 people, like, how was it for you? On either end, asking and reflecting, or being asked an open-ended question and being reflected. Anybody? You feel happier. Yeah. Thanks for sharing. I appreciate that. I think that one of the things that I love about this is it's super, super, super short. So if we think about like how to get a connection that feels good to both people in a really short period of time, that's kind of what we're talking about with patients. And I'm gonna, so thank you. I'm gonna talk about one more, affirming strengths. And for me, this is one of the fastest ways to get a human-to-human connection with patients in a super short period of time that doesn't involve like a really long conversation or listening to perhaps a really long monologue when you're like, oh no, like I'm already behind. It's so fast. And one of the things I want to say about it is I'm a super problem-focused person. Like I was problem-focused before I got trained to be problem-focused in school. So I was always a super good editor. If you hand me something to look at, like every mistake like pops out at me. I like to like mark it up. I have this habit that I had to unlearn where every time like one of my kids would come in the door, I'd be like, why is your hair like that? Or like, what, did you wear that? That shirt's dirty. Like, I mean, everything like pops out at me, you know, I'm just problem focused. And then, you know, I go to social work school for a master's degree in social work. And then I like get a doctorate in psychology, problem, diagnosis, pathology. So I feel like it just solidified it for me. And this has been my practice, yes, clinically, and really honestly, spiritually, for the last 10 or 12 years, is like putting on a different pair of glasses that can see strengths. And it has radically changed my clinical practice. It has changed my relationship with my kids and other people in my family, because when somebody is telling me about something that's troubling to them, before I respond to that in any way, I like put my glasses on and I'm like, okay, I got it. Like 2 or 3 strengths pop out at me. And so before I weigh in on anything, I sort of repeat back and say, gosh, like, wow, I can hear how important your family is to you. When somebody is talking to me about having a super conflictual relationship with like an adult child or with a partner. So it's the problem that they're coming to me with. And for me to kind of pause and be like, wow, this person, like, it is so important for them, like to have harmony, to like be close to this person. And that's kind of amazing. And to say that back to them before I do anything else. I can see how much you love your son. I was talking to one of my friends, also a psychologist, the other day, and I was telling him about all my worries about my son, which seemed really deep to me. And he was listening, he was reflecting, he was asking open-ended questions, and he said to me, God, you love him so much. And I was like, I do. Like, I just almost felt like crying. It just felt so good that instead of seeing my parenting shortcomings, which is what I felt like I was sharing about, he first saw like how big and how pure my love is for my son. And it just changed everything about how I felt. You really care about your health. You know, people still come in arguing against vaccines. I'm guessing that you have it too. The residually unvaccinated or undervaccinated are still everywhere. And oftentimes I find myself listening to someone talk about all the reasons that they've researched that they're not going to get the vaccine. And it's hard, right? It's hard to get out of that judgmental place and like sort of wake up the empathy. And then I often say, you've thought about this a lot and you've done a bunch of research, and I can hear how much you really care about your health. Because even if their decision is different than mine is, or ill-informed, there's no doubt this person does care about their health. That's the only reason that they would be researching and thinking this much about it. So just, these are just examples, but I'll give you one more that just happened a couple days ago. My daughter hates math, wants to litigate every time she has math homework, how useless it is and why she shouldn't have to do it. And I get annoyed, and I'm not, you know, I'm better with patients than I am with my kids. And like, she's like, I hate math. And like, I get into this habit where I'm like, well, you just have to do it, you know, and, or maybe trying to argue it's useful. But what I started doing, and I did this just recently when she said that to me, is I said, you know what, here's what I'm amazed about. You hate math. You actually think it's totally useless and of no value whatsoever. And yet you kind of have the grit and the persistence to just buckle down and do it every single day. Like, you just do it because graduating is super important to you, and like academics are important to you. And like, I love that about you, you know? And it changed the entire dynamic, because previously it could almost get into like slightly argumentative, you know? But I was being genuine. I'm like, what if I put on my strengths glasses for this? I'm like, oh my gosh, how amazing that she just like grits her way through this, you know, even though she hates it. One more really quick. This one's like 2 minutes. So ask your partner about something that's mildly troubling them. And when you're the person who's speaking, you don't have to use something big. You can like move your vulnerability up and down. Don't feel like you have to like dig deep and give something big. Like if I was out there today and you were asking me like, what's troubling you? I would say, God, being here on a Saturday morning, I really wanted to be here. I love SSVMS. I wanted to be here, and I feel super torn about not being at my son's first game. And that, like, I have that tension, just that we all have, I have that tension. That's probably what I would have said. So not super vulnerable. All of us have work-life balance stuff. Some of you might be exhausted. You might have work waiting for you when you leave here. So whatever, something mildly troubling. And then your partner's job is to like pause for a moment and figure out what is the strength in that. So sometimes right before a presentation, I'll talk to one of my friends and I'll say, yeah, I'm really nervous. I always get really nervous. And my friend will say to me, yeah, it's because it's super important to you. And I'm like, yeah, it is important to me. Like, that is why I'm nervous. So that's like an example of like a strength that can come out of a disclosure like that. So this one's really fast. It's just 2 minutes. Go back to your partner or your 3 people. Oh, wait. Oh, yeah. Do you want to 1, 2, 3, 4? Can you go here? Oh, awesome. Ask an open-ended question. You can say, tell me a little bit about something that's mildly troubling you. You can say, what came to your mind when Elizabeth said that? Have that person share, and then affirm strengths. Put on your strengths glasses and be like, what's the good thing that they're sharing with me about this? What's good about them? Okay, finish up. Get your last like strengths reflection in. Are you guys doing that? Are you doing the exercise? That is so awesome. Ah, that is so cool. I love that. The one other reason why I'm really bummed to have to leave right after this is Eileen came up here and spoke, and then she went straight to the massage. I know. So I wonder if someone can share about their experience. Just what was that like? Either looking for the strength or hearing the strength from your partner. Anybody? No? It was easy. I love that. It felt natural, it sounds like. It felt easy. You've got good strength glasses. That's awesome. Yeah. So when you shared your mildly troubling problem, when someone reflected back the strength, it made you feel better about it. Yes. Can I I wish we could spend like another couple hours on this, because one of the things that I'm happy that you shared that is that affirming strengths is related to not just people feeling empathy and not just connecting to people as people, but it's actually related to behavior change. Because it's really hard to change. We always think, like, often we think like people will change behavior when they're feeling really bad. And that is not the case. People tend to change behavior when they're feeling better, when they feel comforted, when they feel heard, when they feel seen for where they are in the moment. The chances of like a behavior change are higher if that's what's going on. But it's super healing. In fact, I have a group of people that are not licensed, and I have sort of a training academy for unlicensed people to do mental health counseling. And they do entire sessions with reflective listening, open-ended questions, affirming autonomy. And people come out the other side feeling fantastic. Like, we get great feedback from patients just from those. So I love that you shared that. I just want to, before we end, this is sort of this one last skill that I wanted to put out, which is affirming autonomy is tricky when we really want someone to do something. But let me just ask you all, when someone is pushing you to do something, what happens in you? It doesn't work. It's because we all have psychological autonomy. Yes, there's some nuanced cultural differences in how cultures appraise autonomy, and it is a human need to have autonomy. And once we feel someone pushing, even if it's like, don't you think, or maybe you should, which is like that little bit of like sideways pushing, we push back. So, and people do not feel empathy from us. It doesn't feel empathic for someone to like push us to do something. So affirming autonomy is when we just say directly to people, especially if we feel ourselves pushing patients, if we feel it and we can almost feel they're pushing back, or if we say yes, but, or they say yes, but, just to take a step back mentally and say, you know, it's totally your decision. It's completely up to you. This is easy to do when it's easy to do. Sometimes it's really hard to do. So I see a lot of pregnant women because of the primary care where I work, does a ton of OB care and deliveries. I see a ton of women who are using cannabis during a pregnancy. It's one of the main reasons that they get referred to see me. And yes, definitely, I mean, it brings up strong feelings when somebody is saying, well, yes, I'm using cannabis because if I don't, then I have panic attacks and I know the stress is terrible for my baby, right? Right? They're kind of like weighing out their reasoning. Number one, huge strength there. I've got someone who is really thinking about the health of their baby. They're not actually right about the stress being worse than cannabis, but this is a person who weighed that out and was like, yes, I'm like really worried about my baby. And that's why I'm smoking pot, because I have so much stress. So I can reflect back and say, man, you really care about the health of your baby. You're really thinking about this. And then as we get into like, tell me what you might already know about cannabis during pregnancy, and like all of these sort of open-ended questions, at some point, and if I'm feeling that internal push, I say to the woman, and of course, you know, it is totally it's up to you, right? This is your decision to make. And what happens after we do that? What do you notice after we do that? Because I know some of you do it some of the time. Yeah, people come towards us, right? They take a step towards us. It's really common for me to say that to people, and a patient will say, well, I mean, I know it's not great, right? They're like walking back towards me instead of sort of backing up like this. So it's super powerful, works with kids and significant others too. I have a friend who's like, anytime you do any empathic communication or motivational interviewing workshops, you should call them "How to Get My Spouse to Do What I Want Them to Do." So just like a word about what I call like connection squashers, or like, you know, that sort of take away from rewarding interactions. Anything that's like shame-based. And I've said all of these things, right, sometime in my career, so I just want to normalize that. But anything that is sort of pushing people with something that has a shame twinge, like I'm disappointed in you, or you need to think about your family, or anything that's super control oriented. So using words like have to, need to, must, really stir up people's kind of, you know, stuff. They start separating from us like this. And then kind of ignoring emotional cues. So if someone is saying, I'm really worried about this, and we're like, you don't need to worry, you know, it'll be fine. Or if somebody's saying, you know, I guess I just feel really demoralized about this, and we're like, no, it's, you know, anytime someone shares an emotion, if we can like capture it and say, yeah, I hear you feel really demoralized, you know, that kind of reflection, it tends to bring us closer. Once we kind of ignore or dismiss those like emotional cues, then people start moving farther away from us because they know this isn't a conversation I can have here. I do have an empathic communication workbook. It's totally free. Everything on my website's free. That is like a fillable PDF. So if you have staff, or if you want to take a look at that, I just want to let you know that. And I love chatting with people. So SSVMS has my email. If you want to email me, and I don't know, anything, just I love to chat with people, and I'm sad that I won't be able to be here for longer to chat with you in between things. So please email me, and that's my website. And thank you again to Eileen and her team for having me today.
Thank you.
Oh, okay.
Well, thank you. That was really great. I took notes, so I'm going to use what you said. So let's actually open it up for questions. Yes, please.
Yes, I have a
Ruth.
question. I'd like to hear your advice. I talk loud. Oh, not that loud though. Okay. I'd like to hear your advice about one way of dealing with what we would call a problem patient that I do, And I know the pediatricians do, and I'll give you 2 examples of that. And I'd love to hear what you have to say about what your thoughts are on it. The babies I deliver who don't take vitamin K or refuse all vaccinations, there are some pediatricians in our community that say, that's your decision, that's fine, but I can't be your pediatrician. And as an obstetrician, when a patient says, I'm not going to do a 3-hour GTT, I'm just not going to do it, I say, but that's certainly your decision. I can give you the reasons why I think it's important. If you don't do that, you're going to need to find another obstetrician because I can't take that liability, but that's certainly your decision. To some of my colleagues, when I say I do that, they say, God, that's hardcore. That's really pressure, and you shouldn't do that. But that's just how I feel.
Yeah. Well, thanks for sharing that. I really appreciate it. I mean, especially because, like you said, some of your colleagues have sort of said, oh my gosh, so I appreciate your courage to stand up and say that. And I think what you're talking about is professional and personal boundaries. That if we're clear as professionals, like about our own boundaries, it's much better to say that out loud to a patient than to continue to try to push and persuade and cajole and coerce them to do what we need them to do. Because I would say a really similar, and I would say that with personal, well, like personal professional boundaries, if you if you don't say that and you continue to see patients, you will burn out and be deeply unhappy and not be able to stay for the marathon of providing critical care. And so I think there is a way to say exactly what you said and say, I am so sorry about this. Because there is I'm sure there's sadness there. Like, God, I wish things were different. I'm so sorry. So for me as a professional, I just can't continue to see, someone who doesn't do this. We do this with pain patients who, continue to use substances while they're on opioid therapy. Instead of saying you need to stop using meth, you need to stop drinking, you need to stop smoking pot, which feels much worse and is a terrible connection and really low reward interaction, we can say, oh no, I'm so sorry. I'm not able to continue prescribing this. Of course it's your decision if you want to drink. And of course it's your decision if you want to keep smoking pot. I won't be able to continue to treat your pain. I think what you're talking about is really important, just to know what the boundaries are. And I think we can say it in a really, really kind way. And even in I'm deeply sorry way, because I'm sure you are having to let go, of a patient. So that's my.
Great, wonderful. Thank you. Any other questions? Oh, yes.
Can I just say I'm feeling really self-conscious because I didn't know we were going to do questions and I don't want to cut into Taylor and Bianca's time. Are we okay?
I think we can go a little long,
Okay.
Right? Yeah, Eileen, I think we can go a little long, right? Yeah, that's fine.
No. Okay.
So a lot of times we're in a situation that a patient comes in and they're already angry with the system. They already had the test denied or the medication denied, or they had trouble with the front staff and they come in, or they may be altered. A lot of times I see patients that are on methamphetamine, they're hyper aggressive, and it's hard for me to be empathic with them, when they're attacking me and, they're in that situation. So one thing that I find very useful in that situation is not to react on my own emotion and just take a step back and just be present in the moment and, let them win, so to speak. So for me, it's hard to be empathic to them right at the moment, but if I just take a step back and just be with my own feelings, I think that works much better for me than, try to fake it.
Yeah, I really appreciate you sharing, and the fact that you've you're being so intentional about how to interact with these situations, that sort of getting with yourself and sort of being with yourself and staying present in the moment. I just love the intentionality behind it. And I would say that when people are angry with us, our empathy gets squashed for everyone. That's why people can say mean things to each other when they're angry. Your empathy literally has just sunk. And so you really don't have it in that moment. And then after you're not mad anymore, you're like, oh my God, I can't believe I said that. Or somebody else is like that because it's back. So I just want to say totally human and normal that when somebody is angry, or if we feel like we're in danger, or both, our empathy will like go through the floor because our bodies are protecting us, right? Like they're like, whoa, go away. I need some, right? I need some protection. So I think what you're talking about, and sort of staying present and not responding in kind, which we wouldn't do. We have a professional obligation not to respond in kind, say mean things to people if they're doing that to us, et cetera. But I also just want to acknowledge how tricky escalations and anger, and I saw that pop up in the Mentimeter, how tough that is, and the fact that they are increasing. But just know that it sounds like you're doing a great job with really difficult situation.
We're going to move on now to the next speaker. I just wanted to say a few things about the Joy of Medicine program. Not only does it provide these tools for self-care, but we also work with health systems to help with system improvements with surveys and other devices. So it's really a great program overall. We're going to move on to our next speaker now. I am delighted to introduce Dr. Taylor Riel. Dr. Riel is a surgeon with some expertise in pancreatic and biliary surgery and pancreatitis. She grew up in New Jersey, trained in Johns Hopkins, and currently is working in Arizona, where she's very involved with the leadership and coaching, also executive coaching, and actually trying to get physicians to go through difficult times, but come out of it resilient and feel good about it. And so I'm actually excited to hear about her talk. One of our colleagues, Dr. John Shuck, who you might know well, speaks really highly of Dr. Riel. And so we're looking forward to hearing all this great information. So without much ado, let me introduce Dr. Riel. Dr. Riel, please come on up.
You've got to hear what I like to call the Facebook version of my life, but over the next 45 minutes or so, you'll get to know the real Taylor. These are my disclosures. My husband and I have a diversified stock portfolio, and I'm also an executive coach, and I have my own coaching business. Probably my greatest disclosure is that the ideas I'm going to talk to you about today come from deeply personal stories and lived experience, and I hope that in sharing that, people in this room benefit. Over the past few years, there's been a lot of talk about physician burnout, and burnout is a threat to the physician workforce. But today, my focus is on well-being. And I think physician well-being is essential to high-quality patient care. And physician well-being extends far beyond the absence of burnout. It's really about the whole person. It's about our physical health, our emotional health, and our social support. Because if someone is struggling, conflicted, or feeling powerless in any aspect of their lives, it keeps them from reaching their full potential in all different areas. And honestly, the term burnout doesn't sit well with a lot of physicians. It suggests that we're not resourceful or not resilient, and we are, by definition, resilient. These are traits that we value and we've honed over years of training and demanding practice. And the term moral injury has been raised to sort of describe what we are experiencing, and it comes from experiences that soldiers have in war, where they basically are perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs. And for us in medicine, that moral injury is not being able to provide the care we want for our patients within the context of our healthcare system, or doing so at great expense to ourselves. And Brian Bowman and the group from Stanford described 3 reciprocal domains of well-being: personal resilience, culture of wellness, and efficiency of practice. Today, I'm going to largely focus on personal resilience, and I do that for a few reasons. So first, I believe that our ability to respond to the stress that's inherent in our environment and our day-to-day lives is at the core of our well-being. Second, it's the only thing that we can control. I can't control a lot of circumstances in my life, but I get to choose how I respond to it. And lastly, I think as we navigate our lives, we all reach what I call pivot points. These are events that kind of shake us to the core and define who we are. And our ability to navigate those challenges and emerge on the other side is essential to our well-being. And there's so many things in medicine that challenges us. The demands on physicians are increasing rapidly, and they include increased regulation, increased demands on our clinical productivity, more patients to care for with fewer resources, rising student debt, inefficient systems, and just plain difficulty balancing our personal and professional lives. And these challenges aren't going to end, and they're not going to slow down, and they place pressure on the entire human system within healthcare. And really, these past 2 years have been extraordinary. With COVID, with the social and political unrest that we see around us, and as I see, the lingering effects of the COVID pandemic in understaffing of our hospitals and things that just further add stress to this system. And all the while, we've all been navigating our own personal challenges during that time. And this is really the traditional model in medicine, right? It's the paradigm that encourages success by running faster and faster on the hamster wheel until exhaustion sets in, with major collateral damage and eventual burnout. I trained in a traditional era, in the most traditional of programs, where we were taught to be strong. So we were told that the only bad thing about being on call every other night is that you miss half the good cases. We may or may not have been burned out. If we did, we certainly didn't talk about it. But I truly believe that at that time, my mentors and role models were propagating the best model of professionalism that they knew. This was a deeply entrenched collection of beliefs that allowed them and their predecessors to override and suppress their fatigue, their poor health, and their sometimes nominal personal lives to fulfill their role as life-saving surgeons. And while it's heroic and romanticized, this line of thought is fundamentally flawed, right? It's flawed in the supposition that physicians and surgeons are somehow superhuman without a need for self-care and a life outside of medicine. And it's even more flawed in the supposition that a physician who allows him or herself to be human and vulnerable is not worthy of our respect or our trust. And traditional surgical culture doesn't help this problem, so I was not raised in an environment that encouraged me to take care of myself. When I was a surgical resident, we literally walked around saying things like pain is weakness leaving the body, and calling each other weak if we called in sick or wanted to spend time with our families. In 2014, I developed neurologic symptoms from an L3-4 stenosis, and I underwent emergent back surgery. 3 days after that operation, I got on a plane from Houston to San Diego to go to a surgical meeting. I couldn't even put on my own shoes. There's so many things that are wrong with this story, but to me, the thing that's most wrong with this story is that my colleagues view this as strong. But does it really represent strength? And then I think, you can talk about the system and surgical culture, but then there's also some inherent personality traits that compound that. So in 2018, I went to St. Louis to give the surgical boards. It's the last day of the boards, it's like a half day. So I wake up at 4:30 in the morning and my plan was to go for a run. But I wake up and I'm tired with the time difference and I'm like, well, it's dark, I don't know the city, I'm just gonna go back to bed. And I'm like, no, don't be lazy, get up and run. So I go out and run and I get about 10 minutes into my run and I trip on a crack in the sidewalk in the dark. And I'm in immediate pain, like my hands are bleeding, my elbows, my knees. So I sit there for a minute and kind of collect myself. Then I get up and finish my run. And I come back, to the hotel, and now it's only like 30 minutes till I have to give the boards. And I'm in so much pain, I literally can't move my right arm and I can't get my sports bra off. I don't have scissors. I'm like, I gotta give the boards in like 30 minutes. So I somehow managed to get my sports bra off and I go and I give the boards and the candidates are coming in and I'm like diaphoretic and I can't even shake their hand. And so I finish the boards, then I fly home. My husband's like, what the hell are you doing? So he takes me to the emergency room where I broke 2 ribs and my proximal humerus. And so I'm sure some people are sitting there and thinking, oh, what a badass, but right, it's totally ridiculous. like any other normal human being, would have gotten this taken care of right away. So it's essential that we take care of ourselves. As I was preparing this talk, I was reminded of a session that I did with my surgical residents in 2019. So in 2018, one of my residents sent me a video on Kinsugi. In Japanese, kin is golden and sugi is healing, and Kinsugi is a Japanese art form where you take pottery and you wrap it in a cloth and you break that pottery, and then you put it together with this beautiful gold leaf filler. And the process is introspective and it's deliberate. And the hammer, when you break that pottery, is symbolic of those pivot points in our lives, of those things that really shake us to the core. And the cloth is really symbolic of the things that hold us together during those times. And then as you put that piece back together, the end product highlights the cracks, and it's beautiful in its own right. It's beautiful and strong in its own right. And I actually went and had the woman come, and I did this process with my residents, and it's very profound if you ever have a chance to do it. But one of the things that you do is after you break the pottery, you sit with the pieces. And for me, this is part that was really hard for me as a surgeon, to just sit with those pieces, because we want to fix it. We want to put it back together, and we want nobody to know that it was broken. But that process of sitting with the pieces is really important, because sometimes you have to sit with them and say which pieces fit and which pieces no longer fit. And what do I want this to look like when I'm done? And so I'm going to talk about several pivot points in my life to just relay some of the things that I learned and I continue to learn. This is the formal definition of burnout, but I actually want to describe my experience with burnout. So in 2014, you would have thought I had it all. From the outside looking in, I looked great on paper, but I felt like I was bad at everything I did. I felt like I was a bad surgeon, a bad mentor, a bad investigator, a bad teacher, a bad wife, a bad triathlete, whatever, because I didn't have time to do any of those things well. I was angry every time my phone rang, before I even knew what somebody wanted. And I remember at the height of this, I was on trauma call. I had literally been up all night, and it was like 3:00 in the morning, and I lay down to go to sleep, and not 10 minutes after I lay down, my pager goes off with a stat trauma. And I literally had to will myself to get out of bed and go down and see that patient. And to this day, I remember that patient. It was a 34-year-old woman who was in a motor vehicle accident, and she was dead on arrival. And I still remember my first thought. My first thought was, good, because I don't have to do anything else. I don't have to sit in the CAT scanner, I don't have to do anything. And I'm probably the only person who would admit that, but I would venture to guess that other people in this room have felt that way at some time in their career. And I thought, this isn't why I went into medicine. I went into medicine to help people. And I wanted something different, but honestly, I felt trapped. I was like, gosh, I have no other marketable skills. And I'm a slave to the lifestyle that a career in medicine provides. And I felt a profound sense of failure, of disappointing the mentors and people who had given me so many opportunities. So this is Robert. I met Robert in July of 2014. And Robert is a sports psychologist who helps athletes achieve their best potential through mindfulness and self-awareness. I like to say that Robert takes winners and he turns them into champions. He coaches their mental game. And I worked with Robert, and Robert profoundly changed the way that I think. So Robert taught me that I could create the life that I wanted instead of having to settle for the one that I had. And he taught me that in every moment I have a choice. I get to choose what I think, how I show up, how I communicate, and the results that I generated. And as I worked with Robert, I thought, he inspired me to become an executive coach. And my initial thought was actually to leave medicine and to coach physicians and people who felt like I did. But as I changed and my life changed, I was like, I don't want to leave medicine. I have this unique opportunity to use my surgical skills, to use my coaching skills, and to use my leadership positions locally and nationally to change the way that we train and develop physicians. So I did that, and I thought a lot about this idea of choosing how I show up to situations. So one of the most profound books I ever read was Man's Search for Meaning by Viktor Frankl. And he writes the book from the unique perspective of a neuroscientist and a Holocaust survivor. And in the book, he talks about the idea that the only thing that can't be taken away from us is our ability to choose how we respond to our circumstances. And he talks about this elusive space between the stimulus and the response where we actually get to choose. And I can tell you that space can be quite elusive. This was a quote from my coaching program, and it says, each moment describes who you are, and it gives you the opportunity to decide if that's who you want to be. In my coaching program, I learned a model called energy leadership. And what this model really did for me was gave me the structure and the framework to find that elusive space between that stimulus and the response and actually choose how I show up to situations. I don't have time to go into the model in detail, but I'm happy to share it with anybody who wants to learn more about it. But it describes 7 levels of energy or awareness. And it just gives you this framework and structure to develop self-awareness and emotional intelligence and choose how I want to show up in my day-to-day life. And it was very powerful for me. In 2016, I actually started a resident wellbeing and resiliency program. So we have 8 residents a year, so we have 50 something in any given year. And we use the energy leadership model as the basis for the program. So it gives us a shared language to talk about abstract concepts like emotional intelligence and self-awareness and communication. And once we set that foundation, we have monthly sessions on team building, on communication, on work-life integration, goal setting, empathy, strategic diet and exercise. The Kinsugi thing was part of this program. And as part of the program, the residents take an assessment called the Energy Leadership Index. It measures something called the average resonating level. And what you need to know about it is basically the higher your average resonating level, the higher your emotional intelligence and self-awareness. But what's really interesting to me is that their average resonating level correlated with burnout, perceived stress, and depression. So the higher their average resonating level, the lower their emotional exhaustion, the lower their cynicism, the higher their professional efficacy, the lower their perceived stress. This is important to me because I know in my coaching, I can impact someone's average resonating level and ultimately impact the outcomes that are interesting to me. In the first year of their program, their mean average resonating level increased from 3.16 to 3.24. You don't know the scale, it's a 7-point scale. But this difference is statistically significant, but it's also clinically significant, and I know just from my coaching. It also decreased their perceived stress, their depression, their emotional exhaustion. It increased their professional efficacy. And on the annual ACGME resident survey that's given every February and March each year, their satisfaction with the program increased from 80 to 96%. And I attribute a lot of that to some of the intangible aspects of the program. We also measured resident satisfaction in 14 different areas of life, and you can see that it increased in a lot of different areas. These are not statistically significant, but they're directionally relevant. And they had improved satisfaction in their personal freedom, their work-life balance, their communication, leadership ability, time management and productivity, energy levels. These are all things that the curriculum addresses. When I came to Arizona, my goal was to create a culture and environment that allows residents to take care of themselves, that promotes well-being. And every day I try to do this because I think if you get the culture right, the rest is easy because engaged, healthy surgeons can do all those things, work RVUs, quality, patient satisfaction. I think culture sets the tone for what's acceptable, and culture drives surgeon, faculty, resident, and staff behavior. And if you find yourself in a position where you don't think that you can change the culture on a grand scale, just remember that you can change that culture one interaction at a time. You can create the kind of environment that we're talking about. Robert also really taught me that investing in myself is an investment in my patients, my family, my colleagues, and my friends. We spend so many years training and dedicating ourselves to medicine that often our identity is wrapped up in being a physician. But there's so much more that makes me who I am. And we need to really be able to feed all these parts of ourselves to continue to be whole. So I often find myself saying things like, I don't have time. And I work with a lot of clients who tell me they don't have time. So I would suggest that every time you hear yourself saying, I don't have time, instead say, it's not a priority, and see how that feels. Now, if that feels good, then I can just set it down over here and stop worrying about it. But if that doesn't feel right, then I need to take a step back and I say, how do I realign the time and energy I'm spending with those priorities? You also have to recognize that your priorities change over time. So sometimes those changes are abrupt. You get married, COVID hits, you get sick, you have a baby, and you are forced to realign the time and energy you're spending with those new priorities. But oftentimes that change is more insidious. It's just this slow change, and you wake up one day and you're like, this isn't really what I want. You're just kind of settling for good enough. And there's a lot of inertia in that direction to make those difficult changes. And I think it's really important that you just step back and constantly reevaluate and realign the time and energy you're spending. It's normal to have these changes over the course of your time. And I especially think as people are transitioning to different phases of their careers, it's really important to step back and to recognize this. This is another pivot point in my life. So this is Winston. Winston is now a 4-year-old golden doodle, and we got him in 2018, and he's enriched our lives in some of the most unexpected and amazing ways. But one of the things I really love the most about Winston is his ability to live in the moment. In June of 2019, like a lifetime ago before COVID, Charlie and I went to South Africa for 2 weeks, and we took Winston to the Tucson Adventure Dog Ranch. You can't make this stuff up. So it's like dog camp, so you go there and they go off leash hiking and swimming, and they play on agility equipment. And every day at the end of the day, the woman sends hundreds of pictures, so, he's having fun at camp, and so anyway, when we're coming back from South Africa, I miss Winston, and I said to Charlie, I said, I wonder if Winston's going to be sad to leave the dog ranch. And then I realized, Winston's not sad to leave the dog ranch. Winston lives in the moment. When I come, he's like, every day he's there, he's like, this is awesome. I get to play and do this all with my friends. And then when I get there, he's like literally so excited, he's wagging his whole body. He's not sad to leave. He's not wondering when he's going to come back. He just lives in the moment. Of course, it's easier for Winston than for me, because this is his calendar compared to mine. And there's so many things in medicine that block our ability to live in the moment, right? So I'm in the operating room and I'm worried about being late to a meeting. I'm in a meeting and I'm worried about a sick patient. I'm with a sick patient and I feel guilty that I'm not home, with my husband having dinner when I told him I would be. I used to be really proud of my ability to multitask, but I've sort of learned that when I do that, nothing actually gets the attention it needs. And so over the last 8 years now, I really have an intentional practice in mindfulness and meditation. I'm actually a really bad meditator, but I do a lot of what I consider active meditation. So if I'm out running, I try to be present in that moment and focus on my footsteps and not let my mind go down rabbit holes. If I'm eating in my office, I just stop and I taste my food, even if it's for 10 minutes. If I walk from my office to the operating room, which takes about 5 or 7 minutes, depending on how fast I walk, I just try to stop and smile at people and say hello. And these things don't add time to my day, but they add space. In his book, The Happiness Advantage, Sean Achor talks about scanning your life for the positive. So not every day is good, but good things happen every day. And it's really easy for those things to get lost in the noise of our day-to-day lives. And he talks about keeping an active gratitude journal to help recognize those things, whatever that is, that beautiful sunset, puppy kisses, ice cream, just recognizing those things. He also talks about random and intentional acts of kindness. I do both, but I really focus on intentional acts of kindness because we're super quick to fire off an email when we're pissed off at somebody, right? But how often do we send an email thanking somebody who's been really helpful? Every day I try to recognize that. And it's really important for both the giver and the receiver. I've also become comfortable with the fact that I'm never going to finish everything on my to-do list. I'm going to die, and there's still going to be stuff on my to-do list. And your day, like mine, I'm sure is like a house of cards, right? So if I go in and one patient gets sick or something happens, the whole thing falls apart. And it's really easy for me to come home at the end of the day and say to Charlie, I didn't get anything done today. And that's not true. I didn't do what I wanted, but helping a sick patient or helping a colleague who is in need is critically important. And so every day now I come home and I try to focus on what I did and not what I didn't do. And so just as an exercise at night, you can just keep a journal by your bed and just write down the things that you did and retrain your brain to focus on the positive. Winston also reminds me that everything I want is on the other side of fear. So Winston's afraid of everything. He was afraid to swim when he was little. It took me a long time to teach him, but this is Winston now. And, fear keeps us in our comfort zone. My coaching program talked a lot about fearlessness. And I thought, gosh, I'm anything but fearless. But fearlessness comes from courage. And courage comes from stepping outside that comfort zone. So I don't like to do anything I am bad at. I don't like to look stupid. And it's fear that keeps me in that comfort zone, right? But it's here, like in the stretch zone, where that courage meets fear, and you step outside, and it's here where you experience growth and fulfillment and kind of grow into yourself. And then that comfort zone gets bigger. Now, when I recognize that fear is holding me back from something, I just shine some light on it. And I just recognize this is going to sound stupid, but as soon as I recognize it, I say, that's just fear. And I move forward anyway. There's also many things in medicine. We just had a talk on empathy, but there's so many things in medicine and day to day that block our empathy. And, I'm sure everybody in this room has seen it, but if you haven't seen it, you should watch the Cleveland Clinic video on empathy. And basically, it's just scenes in the Cleveland Clinic of patients and people just moving around the Cleveland Clinic. And as the video plays, they just have captions above the people's heads, like the tumor's benign, the tumor's malignant, their 19-year-old son's on life support. He just found out he's having a baby. It just shows you like what's going on in people's lives while you're just kind of going through and not realizing what might be happening in someone else's life. Video is incredibly powerful, and I had just watched the video. And then I was rushing to my clinic. I was 10 minutes late, like I usually am. And as I was rushing out of the hospital, I saw this woman, and she was clearly lost. And on another day, I probably would have been like, somebody else will help her. I don't have time, but I just watched the video, right? So I stopped, and she needed to get to the ICU. So I took her to the ICU, and it took all of about 3 minutes. And when I got to the ICU, she looked at me and she said, thank you. She's like, my best friend just overdosed. Like, she said that thing, and I would have missed that connection had I not taken that few minutes to stop. Winston helps me maintain my empathy. He models empathy in a way that humans can't. When I am sad, Winston knows, and he comes and he'll put his head on my chest or my lap, and he just absorbs that sadness with me. He doesn't tell me it will be okay. He doesn't offer solutions. He doesn't tell me about a time he had it worse. He just sits there with me. And he reminds me, also that you don't have to experience what somebody else experienced to have empathy. You only have to be able to connect with the emotion. Because trust me, Winston hasn't experienced anything I've experienced. Sean Aker also in his book says that, our formula for success is backwards. We're taught from a very young age that if we work hard, we'll succeed and then we'll be happy. And we do work hard and we do succeed, but we never get to happy. Because as soon as we succeed, we change the bar. We move it, we want that next thing. And he says that we push happiness over the cognitive horizon. And so I would encourage you to celebrate your accomplishments and to internalize those accomplishments. So we all suffer from some level of imposter syndrome, and we're really quick to internalize every bad outcome, every criticism, every bad thing that happens to us. But we're really quick to dismiss those good things. So how many times does a patient come and thank you, and you're like, oh yeah, it's just my job, right? you blow that off. But when those patients thank you, you say thank you and know that you changed that person's life, because those are the things that keep us going. So this is another pivot point. In January of 2020, I started coughing. And so after 6 months of like incessant coughing and 3 months of treatment for valley fever, 3 bronchoscopies and multiple biopsies, I was diagnosed with lung cancer in June of 2021. And so on June 11th of 2021, I underwent a left upper lobectomy for my lung cancer. And my plan was to start smoking and drinking and eating whatever I wanted, because clearly my other lifestyle wasn't working. In case you're wondering, I'm still in the pre-contemplative phase, because you can't just go cold turkey. But in all seriousness, when something like this happens, it makes you step back and reevaluate. And if you've ever read the book, When Breath Becomes Air, one of the things that he talks about in that book which I read long before this happened, but is really profound, is that like everybody knows they're gonna die, but when you get a diagnosis of cancer, it becomes like very real. And in the book, he talks about the idea that like all of a sudden everything changes, but actually nothing changes because you still don't know when, right? And so it really gave me a lot of things to consider. And unfortunately, this was sort of coupled with another major pivot point that happened right around the same time. So I had been the interim chair of the Department of Surgery at the University of Arizona for nearly 2 years. This was a job that I loved and a job that I was really good at. And around when I was diagnosed for lung cancer, they launched the official chair search for the next chair of the department. And so it gives you a lot of things to consider and a lot of things to think about. But I applied for that job, because Charlie and I love Tucson. We really wanted to stay here. And I was like, look, I got the cancer taken care of. This is what I'm going to do. And in October of 2021, they named a different chair of the department. And he started in March of this year. And, this has been a major challenge. And as I navigate that, I'm just going to talk about some of the things that I think about. The first is that as you're sort of navigating these things, it's really important to define what success looks like for you. For me, at different points in my life, it's been really hard for me to go to surgical meetings, right? Because I said to Charlie, it's like this huge group of people who are afraid of coming in last. Like you go there and you hear the Facebook version of everyone's lives. You hear about their grants and their leadership opportunities and how many Whipples they did last year. And it's really easy to feel like your goals, your accomplishments, don't measure up. And for me, one of the big challenges is I'm always worried about other people's expectations or what their definition of success is. So as I navigate this, it's just really hard for me to step back. So I'm part of this women's chairs group, and their goal is laudable, right? They want to advance women in medicine and surgery. They want to have more surgical chairs. So when I didn't get the job, they're like, it's no big deal. We'll just get you a chair somewhere else. And they don't care if I move to New Orleans or whatever, and so there's that expectation that I should do that. And I'm probably going to be a disappointment to women everywhere. But as I sort of emerged from this, I started looking at chair jobs, and it's just become really clear to me that we love Tucson, and we don't want to leave. I don't want to uproot my family. And there are mentors and role models who just can't fathom that, that they're like, well, everybody wants to be a chair. I'm like, well, actually, no. I wanted to be the chair in Tucson, but I don't want to be the chair just for the sake of being a chair. And so it's just a really interesting thing to navigate, and then it's been a very interesting exercise, because if I want to stay in Tucson, then what is my role here, and how do I again start to feel valued for what I contribute in Tucson? As I was going to talk about this, I even hesitated to bring about these pivot points, because it's easy for me to talk about my experience with burnout, right? Because I got it all tied up in a nice little bow and I can show you that bowl, right? But right now, I'm kind of sitting with these pieces. And I'm deciding, which pieces fit and which pieces no longer fit, and how do I put them back together? One of the things that helped me is sort of remembering my why. So, we all went into medicine at some level to help people, but we lose that. now that I don't have to do all the things I hated to do as the chair, I have more time, and I've actually been seeing more patients and operating more, and I have more time to connect with them in the way that I like. In Tucson, we've built a huge hepatobiliary and pancreatic program, and that program is a huge resource to our community. In the bottom picture is a picture from Kona, Hawaii, and it's a patient of mine named Vaughn. Vaughn had liver cancer in 2008 and had that resected, and then in 2019, she developed a pancreatic cancer. She got neoadjuvant chemotherapy and surgery, and she's now recurred. But we were both in Kona, Hawaii last December, sort of coincidentally. And she took me and my husband out with her entire family who was in Kona with her. And then the picture on the right is Vaughn at her book signing last Friday. So Vaughn wrote a book about her memoirs and her life. And in that, I'm sort of a prominent part in her life. And she invited me to this book signing. And it was just very moving. But this is my why, this is why I do it and why I come to work every day. These are my 3 hepatobiliary partners, Mohammed Kreese and Lucine Mesropian and Carrie Liu. Carrie just joined our team. But they are also the reason I do it. I love to see my residents develop and advance their careers, and these are my junior faculty, and I love to see them do that. The other thing I would say is that there used to be a time in my life where I was like, I'm the only one who can take care of my patients. But you know what? I am not. And the 4 of us don't compete. We really work as a team. We cover each other's patients. We operate together all the time. I help them learn new things. They help me learn new things. We develop protocols that optimize the care of our patients. And having that team takes just so much pressure off. And really developing those functional teams around you with the pace of medicine nowadays, we can't do it all ourselves anymore. When I work with clients, they always have, I work with a lot of smart, motivated people, and they always have goals, and that's important. But I always ask them, well, when you achieve that goal, whatever it is, how will that make you feel? Because really, it's not the goal they want, it's like the feeling that they want. And so while we're working toward that goal, I often say to them, let's bring things into our lives now that create that feeling that you want. So as I'm sitting with these pieces and navigating these experiences, I think, how is it that I want to feel? And for me right now, those things are connection, strength, joy, peace. And so every day I try to introduce things into my life that make me feel that way. In January, I started boxing. My husband thought I was nuts. At first I was like, I'm just gonna go to classes. I'm not gonna spar, but now of course I spar, but boxing makes me feel strong. In July, I took my mom and my sister to Hawaii. Kona, Hawaii is just one of my favorite places. It brings me peace, and my mom and my sister have never gotten to do that. So I got to experience that with them and be connected to my family and the things that are most important to me. They live on the East Coast. And then I met my husband, Charlie, ballroom dancing. We haven't ballroom danced in like 17 years. And so we just started taking ballroom dancing lessons again. So this is us just trying out some of our new foxtrot moves. But again, it just makes me feel connected to my husband and to things that I love. This is the sunset from my patio in Tucson. This is a big reason why I don't want to leave Tucson. You can see the dog, that's my little dog walking on the edge of the pool there. But the sunsets and just sitting out on my patio brings me peace, and running with my friends just brings me peace. And I recently got Winston certified to be a therapy dog. So now Winston comes to work with me, and my husband says, you're not there enough. Now you're gonna go volunteer there when you're not working. I said, well, yeah, but bringing Winston there brings me joy, right? The staff are so overworked and so tired and so impacted by COVID. And when Winston comes, they just light up. When I come to the OR, they're always I'm like, it's just me. So they're just they're like, well, we're happy to see you too, Dr. Riel. I'm like, yeah, it's too late. But anyway, but Winston just brings people joy in a way that I don't, right? And I treat people's medical problems, but Winston treats their hearts. And it brings Winston joy also because he just loves the attention, but it's a wonderful thing to do. I hear people talking about the last 2 years and COVID and just talking about how terrible it is, and it was. And I hear people saying things like, well, when we get back to normal, like when this happens. But John Lennon said, life is what happens to you while you're busy making plans. So it's happening now. You know, during COVID, people in our department, they came to our department, they left our department, they got married, they had babies, they got sick, they bought houses, and, you know, all of these different things. And so live your life now, don't wish it away. My final thought, you know, in 2013, I was in the elevator at UTMB. I was still in Galveston at the time. And on the 6th floor, and the chief resident in medicine gets on the elevator, and I'd known him since he was a medical student. So I said hello, and I said, you know, how are you? And I can still remember his response. He's like, oh, I'm good. He's like, I can see the finish line. And I didn't have the heart to tell him, there is no finish line, right? You know, the journey is the destination, you know, so we have to be enjoying the journey. And so I would encourage you to not be so focused on the finish line that you don't forget to enjoy that journey. I know I'm enjoying I know I'm doing it right when I'm enjoying the journey, and I'm helping everybody, my friends, my family, my colleagues, enjoy that journey as well. So thank you for your time, and I'm happy to take any questions.
Great. Thank you so much, Dr. Riel. That was amazing. Thank you for all those personal stories. So let's go ahead and take some questions now. We'll take one question from the audience and one from Zoom. So let's see if there are any questions. Oh, okay. So yeah, go ahead, George.
Thank you very much. Thank you very much for your insights. One of the things I've noticed over the years is we schedule ourselves to do many, many, many other things, and we don't do any me time. And I think the most important thing we can do is schedule me time.
I totally agree. You know, I put those things that are important to me on my calendar. You know, I'm like, hey, you know, this is when I'm going dancing or boxing or doing whatever it is, and put those things on there. Because if we don't protect that time, it gets overrun. And I think it's even more challenging in 2022 when, you know, when you can work anytime, anywhere. You know, when I have my coaching business, I have to fill out some conflict of commitment form with the University of Arizona. So they ask me, you know, are you going to work? Are you going to do that during business hours? And I'm like, how are they talking? You know, like, I work all the time at home. Like, if I'm going to make a phone call at 2:00 in the afternoon on a Tuesday, then yeah, I'm going to do it. You know, so I just said no. So, but yeah, you know, you have to schedule that time, and you have to. You know, it's easy to answer emails during dinner and all that stuff. So you just have to say, I am not going to do that, you know, but it's hard to set those boundaries.
Wonderful. Thank you. For those of you on Zoom, if you want to type in a question, feel free to do that. For now, let's move on to the audience. Thank you.
Oh, just a quick question. I know one of my colleagues went in for a whole burnout evaluation with brain scans that showed burnout. Are you aware of anything like that, you know, that they're doing on a large scale?
I don't know anything about like programs that include brain scans and stuff like that. I know that like within surgery, the American College of Surgeons has a burnout website where you can continually take things like the Physician Wellbeing Index and monitor your burnout over time. Our hospital certainly doesn't have a systematic way of doing it. And as I think about things, there are some places at Stanford, at Mayo, you know, that are a little further ahead, and they have, you know, programs where they're formally measuring it, but you know, my place doesn't even measure it, you know, like we do in my department and with my residents, but if we can't even measure it, how can we address it? I don't know that we need brain scans and stuff to know. I think it's there. I also think that more and more now people are willing to talk about it. They're willing to recognize it when those priorities shift, because it's not like I had that experience and then I never experienced that again, right? It constantly changes. You know, you constantly have hints of that and you constantly readapt.
Wonderful. Thank you. There is a Zoom question. Is that right? Go ahead.
Correct. Such an amazingly inspired talk. Absolutely fabulous. Can you share any thoughts about the spiritual aspects of this journey?
Yeah, I have a lot of thoughts about that. So, you know, when I started this process, I would not have considered myself a spiritual person at all. And, you know, Robert had me read a book called The Unmistakable Touch of Grace. And in the book, it just sort of talks about, you know, having this vision and this idea, and then all these things will just come to you. And I was like, yeah, grace, something would happen. I would say to my husband, like, yeah, that's grace, but actually that's exactly the way it works, and I've become a very spiritual person. I used to confuse spirituality with religion. It's just very, very different. But the other thing I've noticed is it doesn't matter what you read. So if I read the Buddhist literature, or I read Brene Brown, or I read the Navy SEALs or energy leadership, the message is the same. It's just the packaging that's different. So because of my thoughts on spirituality and my change, I'm very conscious about how I package these ideas so that I can connect with my target audience, so that I can talk to a room of surgeons who won't roll their eyes at me.
Wonderful. Thank you. Oh, right over here.
Thank you so much, Dr. Riel. That was such a beautiful talk, and I really want to thank you for being so candidly vulnerable about your journey. So I thought I had my life together, but I've got some work to do. And I just want to let you know, your Winston is my Mowgli. I couldn't find a husband. I got a dog. I've never been happier. But it's he's put my life in perspective. So I really wanted to thank you. And I think there were some comments you had that were very poignant and very touching, that as physicians, healthcare providers, we're human, and yet we're expected to do superhuman things, right? There's no one harder on themselves when there's a bad outcome than we are, right? We carry this moral burden, this guilt, and I think it's just important for us to remind ourselves to be able to forgive ourselves, to seek help. There's a reason we're all here today, right? Because we recognize there's burnout, et cetera, and that we can do better. But that's just such a beautiful talk, and I'm so, so thankful. Thank you so much.
Thank you very much. I appreciate it.
Thank you. Oh, Carolyn, yeah, right over there. Actually, the microphone's coming to you in a second. Thank you.
Thank you so much for this wonderful talk. I was deeply moved, and as it deeply resonated. I have a specific question regarding the average resonating level. How do you define it, and how can we best increase it?
So I don't define it. So it's actually an assessment that you would take online, just like you would take something like the Myers-Briggs or the DISC. But unlike those things that are like personality profiles, this is an attitudinal assessment, and it doesn't assume like your personality is fixed and it changes over time. I change it when I'm working with clients, really just talking about these things, focusing on self-awareness, helping people understand how they're showing up to situations and how that's impacting their experience, and then helping them respond differently. When you think about some bad situation, you think about my job right now, honestly, the choices aren't that complicated, right? Like, I can continue to be a victim to it. I can change it. I can accept it for what it is, or I can leave, right? Like, so it's not that complicated, but I help people sort of navigate these pivot points and these challenges, and decide, how they want to respond in those circumstances. It's interesting because I can really good at helping other people do it, but it's like really hard myself. I need other people to help me navigate and see that bigger picture when I'm in that space, and that's okay.
Wonderful, thank you. Just of note, actually, if there are any Zoom questions that we've missed over here or for the previous speaker, we will send them to the speakers and then post the responses on the website. So we'll cover everything.
I'm happy to share my email for anybody. You guys can share my email, anybody who wants it.
Wonderful, thank you. So you've heard that as well. A 2-minute stretch break. If you all just stand up. I'm actually delighted to introduce Dr. Bianca Roberts, who is also a friend. Dr. Roberts is on the board of SSVMS. She is a family practice physician, also the chair of medicine at Mercy Medical Group. She also serves as the vice president of the board of directors of Mercy Medical Group. And finally, she is the president-elect of the Sierra Sacramento Valley Medical Society. So we're actually looking forward to her talk today on equity, inclusion, and diversity, the cheat code. And so without further ado, I'm delighted to introduce Dr. Roberts.
Introduction. I'm really glad to be speaking with everyone today. And I must admit, when I was asked to do a talk about diversity and wellness, I was hesitant because in my experience, physician wellness has focused on what the individual can do for themselves to make a better life for themselves. But when we talk about diversity, equity, inclusion, it has more to do with what people can do and organizations can do to make it better for everyone, which is a little shift in focus. So I'm hoping that you'll participate with me today, and then at least one thing that I talk about will be valuable. But it is a little bit of a shift for us today. So over the years, we've had a focus on wellness, physician wellness, what we can do to make it better for us and ourselves and in our organizations. And I've thought a lot about wellness, and it just seems so overwhelming. And I really appreciate our previous speakers because there's just so many aspects to wellness. It just seemed like, is this something that we could ever truly, honestly achieve? Is it realistic? And then one day, I just kind of thought about it, and I thought about video games. So does anyone know what this is? A cheat code, yes. So this is a cheat code. If you were a hardcore 90s video gamer like myself, you knew a lot about cheat codes. These were sequences of buttons that you can put in right when the game starts, before the game starts, and it would give you these abilities. You could skip levels, you'd have extra lives, and I really feel like some of those Nintendo games were purposely not beatable unless you had a cheat code. So this one is one of the best known cheat codes. Up, up, down, down, left, right, BA start. And you would get all of these abilities. So I feel like DEI is one of those cheat codes that can help us gain special abilities and lead us to wellness. But before we jump into wellness and how we use DEI as a cheat code to achieve it, it is important to talk about burnout. And to me, burnout feels a lot like this. So again, for those of us who did 90s video games, you know that is the worst sound you want to hear when you're playing. You've worked so hard to get to that level, you got all the way to the end, then you fell in a pit. Now you got to fall and you got to start all the way over because there was no like continuing or, saving or where you start, where you end. You just have to start over. So burnout is exhaustion of physical or emotional strength or motivation, usually as a result of prolonged stress or frustration. A Medscape survey showed 50% of all physicians in 2021 were experiencing burnout, with noted causes being work-life balance, guess whatever that is, call burden, financial constraints, isolation, lack of sense of community, and female physicians were 1.6 times more likely to experience burnout. But mitigating burnout alone does not necessarily lead to wellness. So then my next question that I have is, what is physician wellness and how would you define it? But before we get some ideas, because again, this is going to be participation, I want to set the mood right. It's taking a little bit of time to load, but we can start passing the mic around for some ideas for how would you define physician wellness? What is wellness to you? What does true wellness look like? I would want some ideas from the audience. So we have one up here. We can use the mic here.
I was looking forward to going to work and seeing your patients. That's physician wellness for me.
Looking forward to going to work and seeing patients, yes.
And then at the end of the day, not feeling exhausted, but instead feeling like it was a day well done.
A day well done, not feeling exhausted at the end. We've done so much work, but feeling good, right? Yeah.
Not just feeling good, but feeling happy.
Feeling happy after the work's done.
Feeling like you're not compromising other parts of your life for your job.
Mm-hmm. Absolutely.
Balance.
Balance. So those are all great examples of wellness. So physician wellness includes the absence of burnout, but also being engaged in our work, having a sense of purpose and community, and all of those things that we noted. So today what I want to talk about is some strategies that we can use to really achieve wellness. And these strategies include developing and fostering high-functioning teams, building an inclusive environment, and also creating a culture of personal support and professional development. And the key thing is implementing and integrating DEI work is critical to implementing these strategies. It's not just about counting racial backgrounds and saying, oh, we have this many Black doctors in our group, so we're diverse and that's great and it's inclusive. That's not what this is about. So I'm sorry that some of my sounds are not working today, so we'll just try to shift a little bit here. But what I'd like to do now is try to get some input from you all about what these things mean. What exactly is diversity? How would you define diversity? So diversity is having representation for everyone. Diversity is being inclusive. Okay? Diversity is having respect for everyone. So today, we're defining diversity as the practice or quality of including and involving people from a range of different backgrounds or experiences. What about equity? That word is being used more now. What is equity? How would you define equity? Treating people fairly. Lifting up people who are not from the same level. And that's right. So equality, a lot of times when we say equity, some people think equality, but equality is providing the same resources for everyone. Equity takes an extra step, and it involves giving people what they really need so that they can be successful. And then what about inclusion? What's inclusion? Not keeping people out. Seeing people as humans.
Having a seat at the table and not just an invite.
Having a seat at the table and not just an invite. Yes. That's awesome. Yes. So inclusion is a set of behaviors that encourages members of a team or community to feel valued for their unique qualities. Okay. So again, like I said, it's not just about having diverse, numbers in our systems. There's more to it. So we're going to jump right into those three strategies. So first, high functioning teams have a positive impact on professional fulfillment and development, contributing to wellness and reducing burnout. So how do we achieve that? First, it's super important to ensure leaderships and committees include diverse backgrounds and perspectives. Time after time, we've seen that diverse teams outperform homogeneous teams. And we know that organizations in the top quartile of racial and ethnic diversity are 35% more likely to have higher financial returns and higher employee retention. So that's the first part of high functioning teams. Then, transparency in the workplace increases employee engagement, builds trust, and increases productivity and boosts morale. And this is really important, that you have to have diverse people on these committees and leaders to help make these policies so that we have different ideas of how policies are made. I think about, work schedules and policies that we have around that. It just can't be one thought of how things have to be done. And, we've talked about that today a lot in medicine. There's not one way of doing things. We have to think differently. And in order to make a change, we have to have diverse thoughts in those rooms making those decisions. And then collegiality is really important. Conducting formal surveys and meetings and formal check-ins to co-create solutions creates a collaborative work environment. Creating a collegial and collaborative environment helps with wellness because team dynamics can affect individual burnout. So step one was developing high-functioning teams. So step two, building an inclusive environment. A prerequisite for creating and developing high-functioning teams is fostering a safe and inclusive environment so that views of all members can be heard and contribute to diversity of thought. So it's really important. I want us to kind of sit with this for a moment and understand that inclusion is not bringing people into what already exists. Inclusion is making a new space, a better space for everyone. We have to change how we think about this. It's not enough just to bring people in and say, oh, you're one of us now. We have to make the space better. And so, in order to create that inclusive environment, we have to understand microaggressions and subtle acts of exclusion. When looking at these, leaders will often focus on what the intent was of the speaker, rather than the impact that it had on the person that was affected. And subtle acts of exclusions, which we'll refer to as SAEs going forward, are words or actions that originate from conscious or unconscious bias. And sometimes people actually do have good intentions with what they're saying, but their words are harmful and impactful. And we have to understand that. So we're gonna talk more, and hopefully the mic will pass around a bit in just a moment. But organizational leaders have a responsibility to protect people from psychological harm in the workplace. And leadership determines whether or not SAEs are part of an organization's culture. A lot of times, leaders often dismiss SAE as insignificant because they didn't mean harm, allowing it to go undressed and accumulate. And physicians who have become subject to repeated acts of SAE will become disengaged, experience more burnout, and will leave an organization or sometimes medicine altogether. They feel like, well, maybe it's not for me. So from May of 2019 to December 2019, Press Ganey conducted a survey of over 100,000 healthcare workers in over 500 organizations in the Press Ganey Workforce Engagement Survey. And the questions explored perceptions of their organization's values in regards to inclusiveness and commitment to diversity. And one of the things that was noted from the results in the survey was that it didn't matter what a person's race was or gender, there were higher correlation of engagement in organizations that were felt to be inclusive. And this went across all genders and racial backgrounds. So being inclusive is really important to gather employee engagement and also for wellness. So, back up. Okay, so we talked about why inclusion is important and how SAEs can lead to not having inclusion. So what I'd like to do is let's talk about some examples. What are some examples of SAE? So remember I said that SAE is their words or actions that originate from conscious or unconscious bias. Sometimes the intent is not to be harmful. I just want to see if anyone has any examples of when it comes to gender or sexuality SAE, something they've seen or have experienced.
Can you just define what SAE stands for?
Subtle acts of exclusion. Subtle acts of exclusion is SAE. Subtle acts of exclusion. Thank you.
So not using correct pronouns for trans patients or gender inclusive language.
Right. Not using the correct pronouns for someone.
Suggesting that as a part-time physician, then I wouldn't be as good of a physician for my patients, and yet how was I going to balance being a mom if I wasn't somehow being able to?
Right, exactly. How are you going to balance being a mom and being a physician? Suggesting you're not going to be as good of a doctor.
Calling the male doctor and the female doctor by their first name.
Oh, I can't tell you how many times that's happened. Yes.
Assuming that I'm the bedside nurse rather than the attending, and that my male medical student is the attending, running
Absolutely.
the code.
Right. Yes. Any other examples? Okay, I have a few. So we hit a lot of those. So like I said, assuming a male colleague is the leader of the team. One that I've seen in the kind of business aspect of medicine, giving credit to a male colleague for an idea that a female colleague already explained. That happens a lot. Cutting someone off repeatedly in a meeting. Calling a woman bossy. We have a lot of surgeons I've heard They're called bossy, everyone else is a boss. Calling a woman bossy specifically. Telling someone, a woman, that you're doing a good job considering that you have all of these family obligations. Or believing someone's not going to be committed to their job because they're a mother or they have family obligations. And as we stated, assuming someone's gender identity and refusing to acknowledge their pronouns, addressing a crowd as ladies and gentlemen can be a subtle act of exclusion, having bathrooms only designated for men or women, or meeting someone's partner at a work function and assuming what their gender identity might be. Those are all, they seem like, oh, maybe not that big of a deal, but they can, lead to acts of exclusion. What about examples of race and ethnicity, SAE? So again, subtle acts of exclusion.
Until we had a diverse wellness group at Folsom, the refrigerator was filled with really not so ethnically diverse food. But once our wellness committee got diversified, now we have vegan, vegetarian, Indian, and other delights in our kitchen.
Right, having differences in that, yes, absolutely.
Refusing to acknowledge or trying to say someone's name just because you can't pronounce it.
Right, yeah, we're just gonna call you Dr. P because that's easier, right?
On spelling my name wrong every time with an L-I-C-K when my nurse knew very well it was L-I-K,
Right, refusing to spell your name correctly. So here are a few. So I've heard this has happened. Oh, calling a black man articulate. Oh, he's so articulate, or you're so articulate. When they're a known speaker, like why, I just don't understand that. Asking someone of Chinese descent, where are you really from? Sometimes people, they seem like they're just being curious, but I'm from Ohio. Like, that's where I'm really from. That's where I'm from, So mistreating a name, as we stated, not making an effort to say someone's name correctly, touching someone's hair. Like this is a really big thing. And I put this here specifically because I can't tell you how many times that someone has tried to touch my hair. You are not invited, okay? Just to let you know, I'm not a specimen. Don't touch me. And making comments like, oh, your accent's so cute. That is just not okay. So what about examples of ability SAE? This one's a bit harder, right? Because we don't think about it as much. So I'll share some. Oh, you have one. Yes. I'm going to use the mic. Yes.
So for patients that are hard of hearing and who have to read lips, now that we're wearing masks, talking louder doesn't necessarily help them interpret what you're trying to say.
Mm-hmm. Yeah, someone's hard of hearing. I'm just going to talk louder, but actually, I need to read your lips. Absolutely. That might discourage them from coming in to get care, right? So I've seen this happen. Telling a colleague who has a disability, oh, you're such an inspiration, which again, could seem like you're giving a compliment, but they might feel like I'm just doing my job, right? And I didn't ask for that extra attention. Telling someone who's in a wheelchair that's moving down the hallway quickly, hey, you need to slow down. You might get a speeding ticket. Like, they didn't ask for that type of attention. Giving eye contact to an ASL translator instead of the person they're translating for. Asking a family member of a blind person if materials are needed in Braille rather than just asking the person themselves. And then there was one more. Oh, not using a microphone in a large group. And I know that we feel comfortable about saying things, speaking loudly in groups, but someone might have trouble. And again, they might not want to come to the group setting because they might be afraid that they can't hear things. So those are things that might be subtle acts. You have something else? Yeah.
I do. I just wanted to bring attention to abilities or disabilities that we can't see as well.
Mm-hmm.
So using people first language as opposed to saying the autistic child or saying someone has autism or that, they're just an anxious person. Well, they're a person with anxious thoughts. There's a lot of abilities and disabilities that we can't see that we also take for granted in how we describe that person.
Right, how we might put a label on someone. And again, that's not necessarily how they view themselves. So those are subtle acts of exclusion as well, absolutely. What about examples of religion, SAE, that we see in the workplace? Bringing prayer into our meetings. Not everyone prays. All of the Christmas, assuming everyone celebrates Christmas. Yeah, that's a big one. Only honoring Christian holidays. It turns out there are some other major holidays. Turns out. Yep. So particularly scheduling meetings, like this is a mandatory meeting for your value bonus. If you don't come, you don't get your bonus, right? And it's right in the middle of Ramadan or Yom Kippur, right? That's just really exclusive. Assuming everyone celebrates Christmas in your office, only acknowledging Christian holidays in the company emails, beginning a team meeting with prayer, asking a colleague several questions, unending questions about their hijab, right? Or when you're picking food options, only having pork as an entree. And I say, oh, well, you can have vegetarian, and there's like fruit as the option. So those are things to think about. And what about age and generation SAE?
There's this term called boomer. It's not very nice.
Yeah, calling someone a boomer. Yep.
So much to say today. Generalizing, saying like, oh, you millennials, or that's so Gen Z of you, or whatnot.
Right. Oh, those millennials.
Asking someone when they're going to retire.
Right. That's a big one. Asking someone when they're going to retire. Aren't you ready to retire? Yep.
Being told you look too young to be a doctor and being asked your age.
Mm-hmm. Repeatedly.
A lot.
A lot. Yep.
For me, it was an XR, which means a digital migrant, assuming that everyone has uploaded an app that is required for special activity.
Mm-hmm. So, like we said, assuming a millennial doesn't know how to work hard. Oh, they're a millennial, I don't know. Telling a colleague that they're not like other millennials. You're not like other millennials. You work really hard. Assuming someone's performance, good or bad, is due to their age. Oh, it's that time. Assuming a qualified candidate is too young for an executive position. Or the alternative, thinking someone is more qualified because of their age. Okay, so leaders have to create an environment that is unwelcome to SAE. So unwelcome to subtle acts of exclusion. So we should expect SAE to happen, but we have to have a culture of psychological safety where we're more aware and informed on how to intervene when they occur. We want to feel empowered. Leaders have to communicate the new norm and explicitly support those who speak up, provide resources, how to escalate things, and also provide guidelines for speaking up. And then third, we should know it takes practice. All of us have a role when an SAE occurs. We have observer, initiator, the subject. We just have to practice on what we might do or say in order to make it a better workplace for everyone. It takes a lot of practice. Training resources and learning modules help us understand the visible and invisible aspects of diversity. So it's important for us to understand that there's just so much diversity. And only doing education modules and those experiences will help us to learn about those things. And with more education about diversity and inclusion, there comes an awareness about the need to advocate for situational needs. And that's where equity comes into the place. So for example, it's just not okay for physicians to have to pump in a bathroom or in a patient room. It's just not okay. So if leaders were in that discussion of when that was decided to be okay, if someone who had the idea of what it's like for that to happen, that just wouldn't happen. So that's an example. Another example might be having not being inflexible to work schedules. And some families were multi-generational families. So you might be caring for elderly parents or for young children. And that basic 8 to 5 type of outpatient schedule might not be okay. So again, having diverse thoughts in those leadership rooms will help figure out ways of how we can fix those kind of things. Some people might need a space for prayer or time in their schedule for prayer. We have not acknowledged that. We don't allow that. But again, we have all the time off for all the Christian holidays and such. We have to think about ways of advocating for others. And then one big one, we have to be intentional about trying to not have meetings after hours as much as we can. And I know that we say, oh, patient care first. It's still exclusive when we have all of the mandatory meetings after work. So, intentionally being inclusive of all opinions and voices leads to belonging. And employee resource groups are a great way to hear those different voices and ideas. And I know some of our organizations have those. So just a little bit about employee resource groups, or ERGs. They were originally formed in the 1960s in response to racial tensions in the workplace. And they help organizations stretch by bringing awareness to different ideas and different issues that are going on. And just some examples, they can make the physical work environment better for everyone. So employee resource groups have done things like working to make gender neutral bathrooms, or they've done things to increase the physical and visible accessibility for people. They also have created a space for marginalized people to come together for some concern or kind of incident that's happened. And then I do think it's important to note that it's really impossible for leaders to get authentic feedback from surveys when people don't feel safe. You know, I know we always have surveys going out, but if people don't feel safe, you're not going to get real responses. And the ERGs are places where people can come together and speak freely in a safe space and really give insight, expert insight, to things about like retention and issues that are going on. And sometimes things might come up that an employee or someone might feel too risky to bring up, but ERGs help overcome that. The other thing is ERGs are great at helping identify leaders for someone who might be overlooked due to unconscious bias or just the lack of opportunities. And they can be super helpful in tackling company-wide challenges by getting those diverse ideas. They can also lower the chance of suppressed frustration because people will be willing to speak out. And we know when our opinion is heard and matters, we're less stressed about it. If we feel that someone has listened and is doing something about something that we care about, we'll be less stressed about it. So these are great opportunities for leaders to get engaged with people. So the third and final step for the 3 strategies is to create a culture of personal and professional development. Allyship, mentorship, and sponsorship are the 3 components of that. So, and I'm so sorry that this is so small, and I think I put it on the second slide. So that same Press-Ganey survey that we looked at, it looked not only at how the healthcare workers were thinking about inclusiveness and commitment to workforce diversity in their groups, in their organizations, but also there were questions that were asked about an organization's commitment to workforce diversity, equality of growth opportunities, the level of which the organizations valued employees from different backgrounds, and how employees felt about each other in regards to feeling welcome if they were from different backgrounds. And on this graph, it showed that green is a more positive perception around opportunities for growth and feeling welcome by leadership and other colleagues, and orange is a less positive perception. If we go down to the physician line, You can see in their non-white physicians in this survey had a less positive perception about opportunities for growth and for the organization's commitment to increasing diversity and leading people to new career opportunities. So one of those aspects, it's really important to understand that mentorship is key to creating those opportunities. And I think of mentorship as the power up to opportunities. So like I was saying, the sound is not working exactly, but you would have heard the power up sound from Nintendo where Mario gets his little mushroom and then he's like big. So if we can think of that, mentorship is that power up. It provides guidance for job transitions and creates career development plans, providing guidance for challenges that occur. It's essential to, if we're looking at growth opportunities for people. And the thing that I want to say about mentorship is that we have to value mentorship. And this is something that needs to be said, that typically committees and groups that are focused on mentorship tend to be voluntary opportunities in our organizations. It shouldn't be. If enhancing workforce diversity is an organization priority, which, like I said, leads to wellness, diversity-related work should be compensated and valued in the same way that research or quality improvement efforts are. And you can pull studies or go back to looking at companies in the top quartile for racial and ethnic diversity are more productive. There's a better return. So there's a reason to actually invest in diversity. We can't just assume that there's no return. It's a known return. So we should be compensating mentors. We should be compensating work done to increase diversity. It will help with retention, and it's really important. Allyship involves advocating for underrepresented groups. We do know, though, diversity alone, as I stated, doesn't lead to a just culture. It doesn't lead to inclusion, but we do still need to have the space to advocate for underrepresented groups. And we went through a variety of different definitions of diversity. We have to advocate for others, and more specifically, when we are looking at opportunities for leadership, every single time a new position opens, the people who are making the decision about who gets hired really need to take a step back and think if their ideas of what a leader is really focuses on stereotypical traits and excludes people. Time after time, we might have heard, well, they weren't qualified. Well, according to who? Like, what's your definition of what's qualified? And I think sometimes we don't realize that subconscious bias really excludes people, whereas if you put someone in leadership that has that experience, you just have to look at it differently. So that's important for leaders to learn about bias and think about when they're making decisions, if they're really not being thoughtful about their own biases. And then sponsorship is using one's influence and network to invest in someone else's career success. So this might be inviting a colleague for a talk, or a new position comes up and thinking about someone else. I mean, maybe you've got 10 positions already. Like you don't need another one. Maybe offer to think about someone else in your organization. Maybe your no can be someone else's yes. So, in summary, DEI is essential to addressing burnout and achieving wellness. Wellness and burnout are not mutually exclusive. Wellness involves not being burnt out, but also having a good quality of life, being engaged at work, having purpose and community, and feeling included. Diversity is a fact. People are different. We're different. Equity is a choice. Inclusion is an action, and belonging is an outcome. We can create a space for all individuals to truly thrive, and we can really achieve wellness. Thank you.
Wonderful. Thank you so much, Dr. Roberts. Let's go ahead and take some questions from the audience. Are there any questions from the audience? Oh, right over here.
When you're looking for new, first of all, thank you. That was super inspiring. I'm in a place of looking for leaders, and I've been, it's been brought up, well, make sure not to be asking people, particularly people of color who are wanting to be more inclusive in our leadership. We don't want to overburden them. I'm like, well, shouldn't we at least ask them and then let them say, but I'm struggling a little bit in that arena.
Yeah, thank you for that question. And I think that might go back to the idea about compensation, right? So if time and space and compensation is associated with the work that's trying to be done, usually people won't be overburdened. Typically, people of color are whenever there's an issue that comes up, we are the expert advice, right? The one person who speaks for the whole community, right? And that becomes taxing. So if you have all of those other jobs that are not compensated for and that you're doing on your voluntary time, then adding another position might be hard. So I would just take a look at, okay, when we're asking for help, we're asking for leaders to come forth, are they being compensated for the other work that they're doing? And I wouldn't be afraid to ask. I think we can't assume that someone won't take a position because they're doing other things. I do think, though, maybe if you offer that position, then the other things that they're doing might open up for someone else, too. So.
Thank you. Is there a Zoom question?
So far, our Zoom comment is that surveys are great, yet many times response results are delayed or non-existent.
Surveys, and I'm sorry for clarification, from the physicians or?
That's my understanding of the statement.
And I think that's why ERGs are really important, because it's a safe space to talk freely. It's not going to rely on some annual survey. And then in that other slide that I talked about, having formal, and so the formal surveys would be that part, but having informal check-ins on a regular basis is a way to get feedback that's more specific. Obviously, we know that feedback is more effective when it's timely and constructive. So ERGs are a great way, the employee resource groups are a great way to get that timely feedback rather than formal surveys.
Thank you for this talk. You really I wanted to learn more about unconscious bias in medicine, and you have touched on quite a few things, but I mean, of course, I would appreciate, maybe you can, guide us as to, what are the other unconscious biases and how do we overcome this? How do we,
Yeah, there's lots of work on unconscious bias and microaggressions and diversity. I think one of the other places in medicine that we don't think about unconscious bias might be language, and then also weight. Weight is a huge one that we have in our community, where we describe patient as the obese patient and then it automatically comes with some thoughts about how a person might feel about their health, which is totally not true. So those are some things that we should be thinking about when we're describing patients, or even sometimes we used to put, I remember when I was in medical school, we changed describing the person's race in the first line to now it's in their social history. So I think there's still some aspect of that. Sometimes there might be a negative association with a person's race, and if we're describing the person in the first line as the Black patient with hypertension and obesity, it may come with some baggage. So we just have to be aware of those kind of things.
Going through your list of SAEs was definitely eye-opening and a reminder and helpful. And I'm wondering, when I'm looking at my organization, if there's lots of people I'm trying to reach, how do I help to educate? So I was educated here today. How do I help to educate my colleagues in a way that is inviting and not like, oh my gosh, this organization has become so politically correct and it's just shoving it down my face, or throat, or, how do I engage them in that process? And have you seen some things that were successful in your organization?
So I feel conflicted on this a lot, right? Because if we make things voluntary, then we're all busy and the question, is it a priority of mine, right? It's not a priority, because if you're not affected by it, it's not a priority. So I think there has to be a combination of required work, which people are gonna just be upset about it, and we just have to acknowledge that. But even if one person listens, maybe there might be a chain reaction that makes a difference for other people and for patients. So I do think there has to be some required trainings. And then I do think that we have to sit with our human resource groups and really create those ERGs, because they're going to be the ones that really put forth the effort to make sure that education about the exclusion that they're experiencing comes out. I don't think there's like one way. I think it has to be, okay, for example, like when we're looking at the gender neutral bathrooms, that's not going to be an issue for people that identify as men or women, right? But for someone who doesn't, that becomes a way of exclusion. Having an ERG that makes an effort to educate people and make changes in the space is what makes that change. I don't think there's an easy way. It's a process. It's slow. It's slower than we want it to be. It's going to take one little chunk, one little bite at a time. And that's, I feel like that's the way to make it successful. And we have to look at, well, what aspects of success, well, how do we define a success, and what can we change on the short term, and how do we look at things on the long term?
Okay, so let's say, asking for a friend, you are a, mid-career, ambitious woman of ethnic descent who finds herself at the seat at the table that you work so hard to get to. And it's a huge accomplishment. And yet you look around and you see that you are the youngest, the only woman, the only physician, the only person of an ethnic descent at the table. And I guess, how do you, what advice would you have for when you feel this overwhelming sense of accomplishment and also intimidation of, how am I, as the one person at this table who worked so hard to get here, going to change what is so entrenched in the culture and the history and the institution within which we work?
Thank you. So obviously, seeing that Black women make up 2.8% of all physicians and are even less in leadership, I understand, right? It's just a fact. There's just not a lot of us, and then even less of us in leadership. There's a book that I read last year. It's called The First, the Few, the Only. I would read that book. And it's not about medicine, but it's about being a woman of color in corporate medicine. And I think that it gave me a lot of thought in understanding that, one, the diversity and thought that you bring to the team is powerful and needed. And I think that, one, when we come into the space of leadership, we think that we have to change to fit the mold, where in reality, we have to be there to change what that mold is, right? So I think that book gives a lot of steps of how to do that. One, recognizing your power. Two, recognizing that you have a voice. And three, how to incorporate that voice into the space. And so that's the first thing. The second is, you can't be the only, right? And that's where that mentorship has to happen. Having those venues of looking at, okay, who else is interested? Whenever, because what will tend to happen, again, when we're talking about being overwhelmed, then they recognize you as someone that is successful, and they want to offer you every single opportunity because they know that you can do it. You have to say no sometimes to offer it to someone else, and make those suggestions of who else might be interested or able to do so. And again, I'm going to put that plug again in for those employee resource groups, because that's where the executive teams can find leaders. You can find different leaders who might not be recognized because of subconscious bias or just because of the lack of opportunities. You have to grow the bench, and the ERGs, they do that. Okay.
Hello. Actually, you built a lot off of my question, which was going to be, what do you recommend for leadership teams to start, which was a bridge off of your question. If you have is there a playbook, or is there something for a leadership team that is new, fresh? And so if you're going to be starting something, or if there is a team that knows possibly they should be doing this and doesn't quite know where to go with it, what do you recommend?
Yeah, so there's a couple of books that I listed, I think, in the references. One is Leveraging Diversity. Well, so actually the book that I was talking about, the first, the only is there, but also the third book down, Inclusion, Diversity, the New Workplace, and the Will to Change. That's a really good book to reference for helping your leaders start. And then there's one, Setting the Stage for a Business Case for Leadership, Diversity, in Healthcare. And then the second book, Subtle Acts of Exclusion, where I got a lot of the references from that we talked about today, is a great book. So I think when there's an opportunity for leaders to do book clubs, there's always in leadership roles, we're always looking at books that we're reading together. Every so often, some of these books should be included. So there's some references here. And then I think there's so much research and there's so much references. Your question about the taxing the same people, there's a book, an article tackling the minority tax. It's a good one to reference as well. So these are all in the slides. There's lots of different references that you can start looking. If you don't have a lot of time to read, there's audio, they're all in audiobooks too, so yeah.
Hi, I would like some comments on where do you draw the line? Because there's so much to deal with in terms of patients and a lot that we don't have for, say, optimal case management and things like that. But as we're working with different generations and having to be sensitive to pronouns, to different cultures, to people's work-life balance and so on, I find it very difficult to stay focused on getting the job done and having people really continue to have that as a priority, as well as accountability, when you have to tread the waters so carefully, not to upset somebody, not to offend somebody, to be sensitive to people, and yet you have so much work to do. And so I'm just wondering what your comments are on how to balance this out as a leader.
Yeah, I think changing the way we think about it, less so about being sensitive to others and more so about defining a new norm, right? So the people who are in the space that's always been inclusive, this is going to be work, right? It's going to be work for someone who's always felt included. For someone who's never felt included, this is life, right? So I think one, changing mindset about that, and then two, I think it's okay to recognize that subtle acts of exclusion are going to happen. It's not saying we're going to have this perfect place where we are always perfect and we never offend people. It's just understanding that when someone has been offended or when those things occur, we have a means or a space to talk about it, to regroup and discuss it, and to educate people about why. It should become the new norm. And I think for some clinicians that are already aware, it's not added extra work for them. It's just a part of how we treat patients. We want to treat patients with the dignity. We want to treat our colleagues with dignity and not exclude people. So I think that the question in regards to maybe flexibility, that obviously there's going to be operational things that have to be put into place, and that might be harder to figure out for an organization. But I think even just being aware and having those groups to try to think about ways that we might make something possible to do is going to go a long way. So I don't necessarily think there's a line that has to be drawn. I think it's more of having that awareness and education and advocating for things that we can make a difference with.
Are there any reflection techniques or tips that you recommend for people to analyze themselves and their past acts of exclusion and how they might be able to improve going forward?
So I don't know about necessarily analyzing past. I just think that it might be in our own way. So I can give an example for myself, something that was more recent. I was working with a medical student in my clinic, and I introduced the medical student to my patient, and I said, oh, this is so-and-so, he's this. And then I thought about it a little bit later. The medical student never told me what his pronouns were. So I just assumed that it was he was a he. So I recognized that, and then after, when we were kind of regrouping and going through the case together, I said, I just want to apologize. I just assumed what your pronouns were. Can you tell me what your pronouns are? And he said, I'm a he, but thanks for asking. And that was it. That took all of 30 seconds. So I think it's just a matter of pausing, being aware, and being able to recognize where our role is when an SAE occurs, and then making that change. It was simple. It didn't require me to do a dissertation and change all of this and that. It was just very simple. So that's what I would recommend. Just taking a step to pause, recognize it happened, ask the person how they might have felt, ask things if it's okay, and then kind of move on from there. Thank you so much.
First of all, I want to thank our sponsors for their investment in physician wellness. I also want to thank the staff here at SSVMS, Sam Mello back there, and then all the others, and then all the others who I can't name everyone here, and then Eileen as well, Wetzel right there, and there are so many others in the back there, and someone on the videographers as well. Thank you all so much. Also, I want to just summarize what we've heard so far. So this was an amazing morning. I felt like I learned a lot, and I hope you did as well. We started off with Dr. Morrison, Elizabeth Morrison, who talked about empathic connection and gave us some tools on quickly connecting with patients and even spouses and our kids and people around us. And those were pretty amazing. Also, Dr. Taylor, who actually spoke on the journey being actually the goal and not waiting till the end. Happiness does not have to be elusive. And what does success mean to all of us? So, and we appreciate all her personal stories to help us on that. And then finally, Dr. Roberts, who spoke on diversity. What does diversity mean to all of us? What does inclusion mean? And the definition of inclusion means making a better space for everyone. And then also talking about the SAEs and educating us on that, and then creating an environment that's unwelcome to SAEs, and ultimately creating an environment that is better for wellness and reduces burnout as we incorporate more diversity. So thank you for that. Also, I want you all to reflect and think about what brought you to medicine. I know we rush through our lives really fast, running through the clinics, and we often forget that. And so maybe an opportunity with all these talks here where you think about those connections you've had with patients and what really brought you to it. Because I find we apply to medical school and we really want to go into medicine, and it's really the top of our mind. And then once we come in here, then it's not as high over time. And so how can we re-engage and find that joy and happiness? Also, just a few housekeeping items. Some of you may have this SSVMS string bag. It's right in the corner there. If you didn't get it, feel free to go pick one up. And then there are these great buttons. This one says, laughter is the best medicine, SSVMS. And there's a whole bunch of them. So feel free to pick stuff up there before you leave. Also, there will be a survey that's going to be emailed to you. And I think it's from NRBI or something. Maybe I got that right. But it's a wellness survey. It's the third year we've been doing it. Please fill that out. There's a $20 Amazon gift certificate if you fill it out, so you get that as a reward. We've actually used that data. It's been very useful. We've given it to the healthcare organizations. We also share it with you, and it helps fuel systemic changes to help improve your wellness. So please do that. Also, don't forget to fill out a survey of the talks you just attended so you can get CME for it. Want to make sure you get that. And then finally, don't forget to go to the SSVMS Joy of Medicine website. It's joyofmedicine.org. There are a lot of tools there. These lectures are all going to be there. The slide decks, I believe, might be there as well. So if you didn't get the pictures of the slides, don't worry about it. You'll see all of that. You can also see the old lectures on there. There are also opportunities to connect with a psychologist or a coach. I think it's a life coach as well. It's a free opportunity for you to do that. So it's on the website. There are also podcasts, really wonderful podcasts that you could look to see if there's a topic that interests you and listen to that. And there's also wellness library, so feel free to enjoy that. And finally, I want to thank all of you, deeply for being here. You clearly have an interest in wellness. You have an interest in your patients. You took a Saturday morning out just to come here. And, we really want to thank you so much